Subcommittee on Health will now come to order, and I will recognize myself 5 minutes for the purpose of an opening statement. Today marks the Health Subcommittee's third oversight hearing to examine the implementation of the Medicare Access and CHIP Reauthorization Act. Personally, for me, the Medicare Access and CHIP Reauthorization Act was a significant milestone because repealing the sustainable growth rate formula was one of my highest priorities coming to Congress. The Medicare Access and CHIP Reauthorization Act represents a fundamental change in a healthcare payment system that had remained static for many years and had created uncertainty for providers. Before the passage of this bill, Congress delayed cuts to Medicare reimbursements for doctors a total of 17 times. Through the hard work and steadfast leadership of the Energy and Commerce Committee and the unwavering commitment from the medical community, this bipartisan effort led to policies that sought to put power back in the hands of those who actually provide the care. That way, doctors will give shape to the healthcare payment system of the future. So it is critically important that the Medicare Access and CHIP Reauthorization Act succeeds, and I am glad that the committee remains dedicated to ensuring that we get payment reform right. It does continue to be one of my top priorities. Today, we will convene two panels of witnesses, and I want to welcome Dr. Jeffrey Baylett, the chairperson of the Physician-Focused Payment Model Technology Advisory Committee, we'll call it PTAC for short, and Ms. Elizabeth Mitchell, who is the vice chairperson of PTAC. I want to welcome you to our subcommittee this morning. In the next panel, we will hear from physicians representing key stakeholder groups that have either already have an alternative payment model or have one in the pipeline with the PTAC or the Center for Medicare and Medicaid Information. With that, I want to take a moment also to welcome Dr. Daniel Varga from the Texas Health Resources Presbyterian Hospital, where I did part of my residency, which provides care for many of my constituents in the North Texas area. It's good to have you in person today, Dr. Varga. The focus of today's hearing will be on the alternative payment models, which is one of two options eligible professionals can be reimbursed under MACRA. The other option is a merit-based incentive payment system, which also deserves our full attention and will be the subject of an additional hearing in the very near future. One of the many goals of the Medicare Access and CHIP Reauthorization Act was to encourage and engage in care delivery models that drive quality while reducing healthcare costs. This movement towards alternative payment methods has allowed providers greater flexibility to innovate and try a delivery system that better aligns with their unique practice needs. It allows them to produce better patient outcomes and offers an opportunity to share in the savings. I am encouraged by figures that indicate an estimated 50% of Medicare payments will be tied to these alternative payment methods next year. We may have heard some of these models before: the Medicare Shared Savings Program through accountable care organizations, the Next Generation ACO model, the Comprehensive Primary Care Plus model, and the Oncology Care model. It is safe to say we will likely hear of them and similar hybrids in the near future. It is notable and important these efforts are physician-directed and physician-led. This is not necessarily the easiest path, but it is the correct one. A recurring theme that we will hear this morning is that physicians are best suited to provide the determinants of quality. Patients are counting on us, not congressmen, but doctors. They're counting on us to get this right. It has been 2.5 years since the Medicare Access and CHIP Reauthorization Act became law. I believe the true potential of this act has yet to be met, but I believe the law has already begun proving a success in delivering better care to beneficiaries, savings to the Medicare program, certainty for our doctors. It is important to hear the positive impact this law has had so far from everyone here today. Finally, it is critical that what we accomplish today follows the same open, transparent, and bipartisan structure that helped us get this act signed into law. I again want to welcome all of our witnesses. Thank you for being here today. Thank you for giving us your time. I look forward to your testimony, and I'll yield the balance of my time to Ms. Blackburn of Tennessee for a statement.
Thank you, Mr. Chairman, and I am so pleased that we are doing this hearing today. And I was one of those that joined you in being a vocal opponent of kicking the can on the SGR. There were things that needed to be done, and it is our responsibility to address those issues and to find solutions. And of course, getting MACRA to the President's desk was a solution. The old system of short-term fixes does not work, didn't work, and I'm looking forward to hearing how the law's alternative payment models are being designed and implemented and improving patient treatment and outcomes in a variety of settings. Being from the Nashville, Tennessee area, we have a lot of health care that is headquartered there, and the steps that are being taken are important to them, to our constituents, and I yield back.
Chair, thank you, gentlelady. Gentlelady yields back. The chair recognizes a subcommittee ranking member, Mr. Green of Texas. 5 minutes for an opening statement, please.
Thank you, Mr. Chairman, and I want to thank you for calling this hearing. I know we were both concerned over those 17 years that how we were going to fix the SGR, and we did come to a bipartisan solution. And my concern, and with this hearing, we don't want to recreate the SGR and have Congress go through that. So as nimble as Congress can be on our feet, we need to make sure we catch it before we have to deal with it for 17 years. The sustainable growth rate was the scourge of Medicare and doctors who treat Medicare patients for more than a decade. Enacted as part of the Balanced Budget Act of '97, the SGR calculations led to a reduction in physician payments starting in 2002 and had to be patched annually, as you said, for 17 years. In 2014, this committee, along with other committees of jurisdiction, finally came together and introduced a bipartisan bill to permanently repeal the SGR and replace it with a system that rewards value over volume and incentives for quality care. Finally, in 2015, an agreement on offsets was reached, and H.R. 2, the Medicare Access and CHIP Reauthorization Act, or MACRA, overwhelmingly passed both chambers and was signed into law. MACRA did more than just repeal the flawed SGR formula. It was designed to overhaul and realign payment incentives for Medicare and transition of our health system to one that rewards value instead of just volume of care. It provided stability in Medicare payments for providers for immediately following years and made it easy for providers to report on and deliver high-quality care by streamlining Medicare's multiple quality reporting systems and over time consolidating them into one. Critically, MACRA encourages providers to move away from fee-for-service and partake in a new delivery models that will reduce costs while increasing quality. Under the law, physicians who treat Medicare beneficiaries have a choice between participating in the merit-based incentive payment system, MIPS, or the advanced alternative payment models, APMs, to make the shift from fee-for-service and volume-based payment system to a value-based payment system. The focus of today's hearing is in the implementation of these two tracks, the alternative payment models. Alternative payment models generally are an approach to provide provider payment that offers incentives to quality, cost-effective care in specific circumstances for specific patient populations or episodes of treatment. Advanced APMs created under MACRA to go to a step further, and under these models, physicians accept some amount of financial risk for the quality of the care and ultimate outcomes of their patients. Participants in advanced APMs accept this risk in exchange for greater rewards when they succeed. Starting next year, qualifying APM participants can receive 5% bonus in their reimbursement annually. Centers for Medicare and Medicaid Innovation Center has developed and piloted APMs since its inception. Many of these now qualify as advanced APMs under MACRA, including certain accountable care organizations, patient-centered medical homes, and the comprehensive primary care plus model. I want to note that one of the most successful ACOs in the country is Memorial Hermann Accountability Care Organization, created and operated by leaders of the Memorial Hermann Health System in Houston, a 16-hospital integrated health system based in Houston. The Memorial Hermann ACO has been #1 in shared savings program ACO in the country for several years running, and by 2016 has generated nearly $200 million in savings across 3 years of participation in the program. Today we hear witnesses from these payment models that currently underway, and physicians participating in them, and which are generating savings to Medicare and improved patient outcomes. Staunch oversight of MACRA is critical. We must avoid the pitfalls of what we did since 1997, and I'm pleased we're having this hearing today and hope this committee engages in more oversight and dialogue as the major reforms of MACRA are fully implemented. And I yield back to my time. Oh, sorry. For the record, I'd like to insert a letter from the American Academy of Family Physicians.
Without objection, so ordered. Chair, thanks the gentleman yields back. The chairman of the full committee has been detained on a conference call. We will recognize him for an opening statement upon his arrival, but pending that, I would like to recognize the gentleman from New Jersey, Mr. Pallone, the ranking member of the full committee. 5 minutes for an opening statement, please.
Thank you, Mr. Chairman, for holding this important hearing, and thank the witnesses for being here today. We're meeting today to discuss one of the great bipartisan success stories of this committee, the Medicare Access and Chip Reauthorization Act of 2015, or MACRA. MACRA built upon the successes of the Affordable Care Act to improve the quality and efficiency of the Medicare program and of our healthcare system more broadly. Prior to the ACA, healthcare services in the Medicare program were predominantly reimbursed on a fee-for-service payment model, which rewarded providers for the number of tests or procedures they performed instead of the quality of medical care provided. And the ACA took major steps towards improving the quality of our healthcare system by creating new models of healthcare delivery within the Medicare program. These new payment and delivery models focused on transforming clinical care and shifting from a volume to a value-based care model, such as accountable care organizations, or ACOs, and patient-centered medical homes. These models prioritize the patient with the goal of improving care coordination and patient outcomes while simultaneously lowering costs. And they have reduced hospitalizations, emergency department visits, and have improved both the quality of care and access to care. There are additional opportunities to refine these models and increase savings, for example, by better targeting the riskiest and costliest patients for interventions. But I want to take a moment to recognize that while we continue to face challenges, the transformation to a value-based healthcare system is well underway. With MACRA, we are entering the next phase of delivery system reform and further shifting the paradigm away from a volume-based to a value-based healthcare system. MACRA builds on these healthcare delivery systems reform efforts by offering opportunities and financial incentives for physicians to transition to new payment models known as Advanced Alternative Payment Models, or AAPMs. And AAPMs must meet a number of criteria and require clinicians to accept some financial risk for the quality and cost outcomes of their patients. Physicians can join existing and successful models that qualify as AAPMs, such as ACOs and the Comprehensive Primary Care Plus, or CPC Plus model, which we'll hear about today. They can also develop their own models known as physician-focused payment models. A number of physician organizations have already submitted applications for approval by the Physician-Focused Payment Model Technical Advisory Committee, or PTAC, and PTAC has been accepting and reviewing applications for physician-focused payment models over the last year and has approved several for testing, including the ACS Brandeis model, which we'll hear about today from the American College of Surgeons. I look forward to hearing from PTAC about the application process, where these efforts fit within the broader context of delivery system reforms, how these submitted models have been evaluated, and how models may be implemented going forward. Our second panel of witnesses practice in a variety of settings across the country and represent diverse expertise and training. They each have a unique perspective to share with us regarding the implementation of MACRA and how it has encouraged a focus on quality and efficient health care. And I want to thank you all for your commitment to delivery system reform. It's only through sustained commitment of the leading physician organizations and clinicians such as yourselves that we can hope to bend the cost curve. So I look forward to discussing the tools and best practices providers are already using, some of the challenges and opportunities they have faced, as well as future efforts that can be employed to help make MACRA work effectively for all. So I thank you. I don't think anybody on my side wants the time, Mr. Chairman, so I yield back.
Gentleman yields back. The chair thanks the gentleman. Chair would remind members that pursuant to committee rules, all members' opening statements will be made part of the record. And we do want to thank our witnesses for being here today on both panels. We thank them for taking their time to testify before the subcommittee. Each witness will have the opportunity to give an opening statement, followed by questions from members. Today, we will hear from Dr. Jeffrey Baylett, Chairperson of the Physician-Focused Payment Model Technical Advisory Committee, and Ms. Elizabeth Mitchell, Vice Chairperson, Physician-Focused Payment Model Technical Advisory Committee. It's a mouthful. We appreciate you being here today, and Dr. Baylett, you are now recognized for 5 minutes for an opening statement, please.
Thank you. Chairman Burgess, Ranking Member Green, and distinguished members of the Energy and Commerce Subcommittee on Health, thank you for the opportunity to testify on behalf of the Chair and Vice Chair of the Physician-Focused Payment Model Technical Advisory Committee, or PTAC. We are Jeffrey Baylett, Executive Vice President of Healthcare Quality and Affordability at Blue Shield of California. We insure 4.1 million members. We're nonprofit and the third largest health plan in California. And Elizabeth Mitchell, my Vice Chair, CEO of the Network for Regional Health Improvement, a national network of multi-stakeholder regional health improvement collaboratives with over 30 members across the U.S. As an otolaryngologist, head and neck surgeon, and as a Blue Shield Executive Vice President, I'm responsible for leading all medically related activities for the health plan, including quality medical management, provider contracting, and our accountable care organization strategy, and I also serve as the chair of PTAC. Thank you for extending this opportunity for us to speak on the important topic of Medicare payment reform and PTAC's role supporting physicians and clinicians as they transition to value-based care delivery. Even before the inception of MACRA, there was considerable agreement that the current fee-for-service model based on paying for the volume and intensity of services is unsustainable and needs to change to a model that is value-based, patient-centered, and accountable. However, we need to transform the care delivery system and change the trajectory of spending in a way that maintains the vibrancy of the institutions and professionals that have dedicated their lives to preserving health and caring for the sick, injured, and dying in the U.S. MACRA and alternative payment models have the potential to address the fundamental drivers of cost and quality and ensure that we have a high-value health system, the backbone of which is providers who want to change care delivery and give better care to patients. As the largest purchaser of health care in the world, Medicare has considerable influence on payment, and through the development of alternative payment models, drive market change. And the PTAC plays an important role in accelerating model development. The PTAC is an 11-member advisory committee established to consider physicians and other clinical stakeholders' proposals for new payment models that foster high-quality, high-value health care. PTAC members are a diverse, highly talented group that have deep expertise in clinical care and technical expertise in the areas of measurement, payment, and care delivery reform. The committee includes a balance of physicians and non-physicians who are highly committed to ensure that proposals are critically, thoroughly, and expeditiously evaluated. We have sought to establish high-integrity relationships with the clinical and broader stakeholder communities across the country, some of which you'll hear today. We're inviting comments, questions, or concerns prior to and during public meetings when models are evaluated. Furthermore, PTAC is keenly interested in all types of models, including those emanating from single specialty primary care, small and rural practices, sophisticated health systems, and multi-specialty group practices. PTAC's disciplined and collaborative efforts have garnered tremendous interest and creativity from stakeholders, receiving 33 letters of intent and 20 full proposals spanning many specialties, payment types, and practice sizes. To date, the PTAC has held 9 days of public meetings. We've deliberated on 6 proposals. We've voted on 5 with submitted reports to the Secretary, and we have 14 proposals under active review. It is our belief that the interest in and work of PTAC confirms Congress's direction and intent for MACRA to transition U.S. healthcare to a high-value system, delivering better care at lower cost. Lastly, PTAC works collaboratively with CMS and CMMI to garner input about specific proposals, especially if they have been previously evaluated in any capacity by CMS or CMMI. To date, the models PTAC has sent to the Secretary for potential limited scale testing have not been approved. In addition, we are unclear whether, because of the extensive review process already provided by the PTAC, submitters can undergo a more expedited review and evaluation process. Our concern is that if we are not able to support our recommendations or work to fix any shortfalls in our analyses, the value of PTAC's process will not be fully realized. We believe that closer coordination between PTAC and CMS and CMMI will enable greater efficiency, greater capacity to implement more innovative models, and greater clarity for applicants seeking to understand the process of submission and approval, and look forward to continued partnership with CMS and CMMI. In closing, PTAC is an incredibly important forum to identify innovative models from the field to expand Medicare's payment model portfolio. Transforming care delivery, including implementing innovative payment policy, is complicated. Therefore, an open public process that includes the stakeholders and also educates stakeholders and the public is likely the best way forward. We believe the PTAC is well suited for this purpose. We commend Congress for its vision, and we thank you for the opportunity to be part of such important work. Thank you.
Chair, thanks, gentlemen. Ms. Mitchell, you're recognized for 5 minutes, please.
Thank you, Chairman Burgess, Ranking Member Green, and distinguished members of the committee. Thank you again for the opportunity to be here today and for your leadership on these critically important issues. As President and CEO of the Network for Regional Healthcare Improvement, my members and I work at the community level with all stakeholders, employers, providers, health plans, patients, and others. And I can assure you that healthcare quality and affordability are of primary concern. The urgency to reduce healthcare costs while improving quality cannot be overstated. This is impacting families, employers, state governments, and our overall economy. MACRA addresses the fundamental drivers, and by reforming care and payment, we have truly the opportunity to achieve better care at lower cost, and this is an incredible opportunity for the U.S. Dr. Bailett has shared the innovation and leadership that we have seen from the physician community and their readiness to lead these changes. This is an opportunity that we cannot squander. Despite the exceptional interest in PTAC, as evidenced by the number of proposals and letters of intent, there are still barriers that physicians face in transitioning to these new models. Providers who are ready and willing to lead change continue to face barriers and need additional support. The PTAC took the time to think about some of the key barriers that we have seen from the submitters over the first year, and we have identified 3 priority areas for your consideration. These include the need for technical assistance to providers, greater access to shared data, and the opportunity for limited scale testing of innovative models. PTAC believes that there is a material need for technical assistance for providers to develop and implement physician-focused payment models and APMs. Most physicians, they have experience changing care delivery, but they have not been trained in the development of incentives, payment models, or risk management. Recent surveys of high-performing health systems and medical groups demonstrate the growing willingness to support and assume risk, but these organizations have made considerable investments in the infrastructure to successfully participate in APMs. And while large health systems may have the resources and expertise to develop and implement these models, such small and rural practices are at greatest risk of not being able to afford the technical support to design and implement the payment and care changes needed to succeed under risk-based models. This threatens to leave these small and rural practices out of the transition to value-based care. Congress should identify ways to enable the provision of technical assistance to providers seeking to develop and implement APMs in a way that does not exacerbate resource differentials among providers and that helps move all providers forward towards value-based care. Although MACRA does not authorize PTAC to provide such technical assistance, many members of our committee believe that PTAC should be able to do so, or at a minimum, PTAC can provide valuable insights related to what types of technical assistance would be most helpful. The PTAC supports deployment of HHS resources to provide access to analytic, technical, and quality improvement support. We also believe that there is a need for greater access to shared data. This is a common barrier identified by submitters. PTAC 2 has observed common weaknesses among some of the submitted proposals. Specifically, applicants need community-wide all-payer claims and clinical data sharing across communities to successfully implement models. Providers cannot manage risk, care, or cost without timely, comprehensive data. Most of the proposals PTAC has received require coordination of care across practices, providers, and communities. But if data is not shared effectively, participants cannot coordinate patient care across episodes or populations. Data blocking, lack of interoperability, and other limits on data access continue to be a major barrier to care improvement on behalf of patients. The move to APMs as required by MACRA has made this an urgent issue. We ultimately must address the barriers to community-wide data access in order to enable the successful transition to APMs. Finally, limited scale testing of innovative models is necessary before we scale models for national implementation. This is the committee's third priority, and we believe that innovation in any industry requires the opportunity for small-scale testing. PTAC has identified limited testing of models as an important phase of development and implementation, as it is unknown how key elements of the model will clinically and financially perform until the model functions in a testing environment. Given the diversity of markets across the United States, regional testing will also identify aspects of the models that may require flexibility in implementation. We do not expect a one-size-fits-all approach to reform, and we believe limited scale testing of these important innovations will allow successful transitions to alternative payment models. In closing, I want to underscore what my chair has said, that we are seeing excitement and innovation and enthusiasm from the field. We see clinicians who are ready to lead transformation in care and payment, and we think this is an incredibly important opportunity to support the move to alternative-based payment models for a high-value health system. Thank you.
Sure. Thanks both of our witnesses for their testimony this morning. We'll move to the question portion of the hearing, and I'm going to recognize myself 5 minutes for the first round of questions. And Dr. Bailett, it's my understanding that during the summer you communicated with the Department of Health and Human Services, identifying a number of opportunities where your group can provide or improve payment model development. And I think I heard in Ms. Mitchell's testimony the answer to this question, but I'm going to ask you, does PTAC need authority to specifically authorize its ability to provide technical assistance through the APM development process?
Under the statute, MACRA remains silent on whether it gave the PTAC the authorization to provide technical assistance. As we said in our testimony, there are significant interest by PTAC members to provide technical assistance. As I said earlier, there's some very skilled, highly talented folks who really understand how to build these models, both clinically and also on the financial business side and the measurement side, to make them successful. We also understand that the PTAC has a role to play relative to evaluating models, and providing technical assistance does cause potential conflicts. If you think downstream, supporting particular stakeholders, and then we then at the same time evaluate their models, depending on how that turns out, you can see that there could be some downstream complications. Despite those challenges, we still believe at a minimum that we should, because of our exposure and the insights that we gain from working with clinical stakeholders, we think we can be at a minimum a beacon to cast the light on particular areas that submitters are struggling with or are challenged, that the global stakeholder community can learn from. And I think that is at a minimum a role the PTAC should play. I do think, to answer your question directly, that this question of can the PTAC provide technical assistance, that needs to be answered definitively, and so we would look to you for clarity on that.
And are you free to disclose your communications with the Department of Health and Human Services this summer? Were they positive in their comments toward you, or?
Yes. Yes, we sent Secretary Price a letter. We've had private conversations with him as well. Very supportive, understands the importance of technical assistance. Again, we have spent a year before we accepted our first proposal, standing up the committee, building in a process. We want these models to be successful. But stakeholders, depending on their level of sophistication and experience and the infrastructure investments, they come at it from different places. This is new, and we're all learning. So I think it's absolutely paramount that technical assistance be delivered. I believe the word we got back, and I'll let my colleagues speak as well, that the receptivity for technical assistance exists. I think the mechanics of how it would be distributed, how it would be identified, and how it would go out to the stakeholders, that remains an open question.
Very well. Ms. Mitchell, did you have something to add to that?
I would only underscore the demand we are hearing from across the country. Again, physicians understand clinical care delivery, but a lot of this work in incentive design, risk management is new. PTAC has recognized the urgency of this. We do not have clear authority to address it. We think that somewhere HHS needs to find a way to meet the needs of providers so that they will be successful.
Okay, thank you. Thank you for that observation and the acknowledgement that it may require legislative activity, not just administrative activity. So I'm going to ask you a question. I mean, it comes up all the time. The hiring freeze that the administration has imposed across all levels of the federal government. Is your PTAC, is it currently subject to a hiring freeze?
It is our understanding that they are subject to a hiring freeze. I think it is also important to note the volume of activity, which I think is an indicator of success of PTAC, but it has also been more than we have anticipated in terms of time demands. This is, again, also highly technical, complex work, and I think having the right staff is critical. We have had excellent staff support. We just think that given the demand, there is need for additional support.
Very well. We've previously asked the administration to evaluate an exemption for PTAC, and we will continue to communicate with them. Just in my last few seconds, I just want to make the observation. I downloaded the application form, and man, it is lengthy. I was actually going to provide a little technical advice that there ought to be a worksheet or checklist. Actually, there is one, but it's way deep in the weeds here. Maybe that ought to be advanced to right after the table of contents.
Well, we appreciate the concern and we recognize that it is lengthy. However, the committee really felt that it was our job to make the instructions as clear as possible and complete as possible. So we are hopeful that this is actually a helpful document. You'll note there's even visuals in there to explain the process. Again, this is meant as a tool for assistance to submitters. Dr. Bailett, any?
I think the only other comment is, as we design this, we really put ourselves in the eyes of the stakeholders. Sure. And we were thinking, this is new, our process is new, we wanted to be entirely transparent. And if you look at the document, it is constructed, there's a lot of definitions. All 10 of the criteria are spelled out through the lens of the committee. What is it that the criteria is trying to accomplish? What is the committee looking for to see in these proposals? Because again, I'll go back to my earlier comment, we want these proposals to be successful. We also are taking feedback from the clinical stakeholders about our process. They have provided input, and we have revised our process based on that input, and we will continue to do so, and we will take this comment under advisement as well.
I'm sure we'll have continued conversations. My time has long since expired. I'll recognize Mr. Green, 5 minutes for questions, please.
Thank you, Mr. Chairman. I think we'd be happy to work with you to see what we can do. We don't want to have this process fail because we don't have staff or quality staff, or that you can't provide assistance. That just seems silly. But be glad to work with you on that to see how we can do. Dr. Bailett and Ms. Mitchell, thank you for being here today and your insights. I would like to ask about PTAC's mission and what you've set out to accomplish. From my perspective, PTAC and the PTAC process evaluating physician-focused payment models is uniquely in the delivery system reform context because it's driven primarily from the ground up by provider. How does PTAC fit within the broader delivery system reform efforts?
Thank you. I think one of the consistent themes that we hear from submitters and we've experienced in our day jobs is that there are many clinical improvements that providers know could be made that would make care better for patients, and the current payment system is actually a barrier to making those changes. Many physicians will tell you they will lose money trying to do the right thing in many cases. The fee-for-service system often incents duplication, redundancy, overuse. So this is actually a forum, in my view, where clinicians can bring models for better care and hopefully have a payment system that supports those changes.
Well, and that's what I hear from my physicians, that they're concerned about what the end result, so they want to have the input. And the unique benefits and challenges does have a model, challenge. But from my understanding, PTAC is comprised of 11 members appointed by the Controller General. Each of these members are nationally recognized for their expertise in payment and reform and alternative payment models. PTAC's members include both physicians and non-physicians. I know it's beneficial for having both physicians and non-physicians there because to get the process moving. How does your review process engage stakeholders and the public along each step of the way?
So we have a multi-step process, and if you'll indulge me, I'll walk the committee through it as quickly and efficiently as possible. So working with the ASPE staff, using our primer on how to submit a model. The model is submitted to the committee formally after a letter of intent is sent 30 days in advance. And the only reason the letter of intent, it's non-binding, but it just helps us staff appropriately. We need to know how many models are out there and potentially coming in, and that was the purpose of that letter of intent. When the proposal is submitted, the ASPE staff check it for completeness to make sure that all of the appendices and the references in the document is complete. At that point, the model is transitioned to a review committee, which is comprised of at least one physician and 2 other members of the committee, to review the contents of the proposal, and then they go about working with the stakeholders, the submitters directly. There's a question and answer. Typically, it's at least 1 pass, if not 2 or more, in writing in exchange for clarity on particular points in the model. And then we host a call with the submitters for additional clarity. During this entire process, the proposal is published for the entire stakeholder community nationally to see. We get comments from the stakeholder community globally, either in writing. We also have them come to our deliberative meetings in public and make public statements about their concerns, questions, or support for the models. Following the exchange between the stakeholder submitter and the PTAC review team, we then go to the national expert clinician. We have, if it's on renal disease, we will speak with a qualified renal nephrologist to get their perspective on the elements of the model and help sharpen our focus and answer our questions that we still may have about the model and the proposal and how does it work in the real clinical environment, if you will. All of this time, the full committee does not deliberate. As a FACA committee, all of our deliberations have to be done in public. So the proposal review team creates a document after all of their work on their recommendation based against the criteria of the secretary. It is non-binding, but it is directionally helpful for the full committee when we sit down for the first time in our public session to then deliberate and review. And if I could, that particular session, how it starts is the review team reviews the model for the committee. We then invite the stakeholders up to the table. They either, so far, they've been all coming in public. They've been coming to the public meeting. They then have an exchange that typically can go on for an hour where we talk with them about questions that we have or sharpen our focus on the model before we deliberate because we want to make sure we understand the nuances of these models. We also have public come before we start to deliberate. So then the public comes up, they provide their input, and at that time, the committee goes into the deliberative mode. We discuss the model amongst ourselves, and then we vote against the 10 criteria on an individual basis. So we support it. Well, we don't support it. It doesn't meet the criteria. It meets the criteria or meets the criteria with priority. We do that through all of the criteria, and then we vote on the model in general, at making the recommendation to the Secretary to support with high priority, or to support it with a limited testing. That is the process, and it's exhaustive, and we're really happy to be part of it, but it takes a lot of energy to get it done.
Thank you, Mr. Chairman. I know I ran over, but these are issues that, again, we don't want to come here 5 years from now and have to see what we didn't do now.
Right.
So
Thank
we
you.
appreciate your explaining the process.
Chair, thanks, the gentleman. Gentleman yields back. Chair now recognize the gentlelady from Tennessee. 5 minutes for questions, please.
Thank you, Mr. Chairman. And I want to stay kind of in that same vein where Mr. Green is, because one of the things I think many times we will do is something gets passed, it gets on the books, it takes forever to get it straightened out. And when we're looking at the APMs and the utilization of technology in this process, it changes so quickly that there has to be a nimbleness that we have not seen before. And I assume that each of you agree with that because you're shaking your heads in the affirmative. But let's stay right with you, Dr. Ballet, and let me have you talk a little bit more about timeline, a little bit more about process. And Ms. Mitchell, I want you to weigh in on how we are, when you have this integration, if you will, of the physician, which is an incredibly important component of this, and the other two stakeholders that are involved in this process. Talk to me about how that relates to our rural and underserved areas.
So I'll start with the timeline in the process. We are very sensitive and acutely aware of the need to get these models in the field. Physicians are being measured as we speak today for payment that will impact them a year and a half, 2 years downstream. So we did not want to be a rate-limiting step as these models came forward. We measure as we move through that process that I described, those measurements are done in weeks. It typically takes about 2 weeks for us to get back to the stakeholders with a series of questions.
So basically, you're doing an expedited process and approving as you go.
Yes.
Okay.
We don't well, because of our public schedule, because we can't deliberate in private,
Okay.
the deliberation, we batch them. So we have a meeting next month. We have 7 proposals we're going to go through 3 days of public meetings.
All right, and then let me stop you right there. Ms. Mitchell, talk about this as it relates to the rural and underserved areas and how you're feeding in that data, because data is essential to this.
Certainly, I'll try. I think it has been very important that there is a balance on the committee of physicians and non-physicians. I'm one of the non-physicians. My background is actually working with multi-stakeholder groups at the community level for transforming care and payment. I am from Maine, highly sensitive to the small and rural issues. I think because we are receiving proposals from the field, we are receiving proposals from small practices. I believe you'll hear that on the next panel. We are, I think as a group, we're a diverse group. We are committed to ensuring that everyone can succeed under this model. And that's actually one of the reasons that we are particularly urging technical assistance, so that it isn't just the well-resourced health systems that can afford these.
So you're deliberate and intentional in having individuals from these rural and underserved areas.
Well, we don't actually control who comes to the committee. We respond to the proposals that we receive. However, we are certainly trying to promote the opportunity, and we certainly welcome and weigh the issues of small and rural practices to the extent possible.
Okay, and let's look at the high-performing hospital or health systems and medical groups. And just a couple of comments quickly, I've got a minute left, on how you characterize those groups' interest in risk assumption?
The larger, more sophisticated integrated systems, they have already made the infrastructure investments, whether it's electronic health record, they have the modeling, they have the data analytics, the population health tools that really help them be successful in an alternative payment model environment. And so they're very much, they're ready and willing, and some of them, many of them across the country are already in alternative or advanced alternative payment models. So they are sort of leading the way, if you will. That said, I would be remiss if I didn't mention that the smaller practices have a high degree of nimbleness that the larger practices don't necessarily have and can move very quickly, but they also need help with the infrastructure.
And if I might just add to that, the small and rural practices may be providing exceptional care. We think that this might provide greater flexibility to them so that it isn't, again, the one-size-fits-all approach, because we recognize that care will be delivered differently in different communities and in different size practices.
Right, and that is the nimbleness that I think we're wanting to see and the flexibility that we want to see on this, and we're not going to be hesitant to continue to do oversight and to pull it back if we think it needs adjustment. I yield back, Mr. Chairman, thank you.
Chair, thanks. The gentlelady. Gentlelady yields back. Chair, make the observation. That's the third time the word nimble has been used. I don't recall that ever happening in a committee hearing before.
It's tough for members of Congress to be nimble.
Chair recognizes the gentlelady from California, Ms. Matsui, for 5 minutes, please.
Thank you, Mr. Chairman. I'll try to be nimble. So thank you very much for holding this hearing, and thank the witnesses for being here today. You know, as you know, we came together in a bipartisan way on this committee to fix the broken SGR and replace it with a MACRA. And I'm pleased that you're making progress with the goals set forth by MACRA to truly transition our Medicare payment system from value to volume. As you stated in your testimony, Medicare has considerable influence on payment, and that can drive innovation. That is what I'd like to focus on today. Every witness here is testifying to the hard work providers are putting in to update their systems of care and develop payment models that adequately reflect that. We're hearing about care coordination, patient-centered care, and better management of chronic diseases. I believe that technology, whether in the form of data systems measuring quality, interoperable electronic health records, care delivered remotely, or conditions monitored remotely, will be integral to our success in achieving our goals of higher quality and reduced costs. Thank you, Dr. Bailett and Ms. Mitchell, for your leadership on PTAC, and I appreciate the dedication you bring to your work. I would like to focus on this issue of telehealth and health IT. The 10th criterion for judging APMs is to encourage the use of health information technology. Either one of you or both of you, can you expand upon that? How does the PTAC ensure that models are encouraging the use of health IT?
I'll start. It absolutely is essential, especially when you realize the diversity of the care that's delivered across the country and the shortages in particular areas where certain specialty services, for example, are not available. So leveraging technology is absolutely essential. You mentioned telehealth, making sure that patients, members have access to high quality specialists through telehealth. There's a lot now with technology with your smartphone. Right. A lot of diagnoses can be made using your smartphone, for example. So we need to leverage that technology, and we embrace the submitters who put technology in front and embed that in the model. There are some challenges with that, and the Secretary has commented about proprietary technology. Sure. Because that obviously limits the deployment and the implementation of these models. But the notion of leveraging technology to drive care into the communities is absolutely essential. Okay. Getting everyone on a health information platform, and as you know, being from California, my organization with also Blue Cross, sure. We have built an HIT platform with over 25 million records.
Okay, can I ask you this then? So I assume health IT, electronic health records, devices that remotely monitor, clinical decision support software, software that helps clinicians on team communicate securely, and to allow providers to deliver care remotely. It includes all of this. So are there experts on the PTAC that specialize in health IT or have extensive experience with it? Does PTAC consult with such experts? Because I know you've got a balance of people on their physicians and non-physicians.
I think, to your point, there is a range of expertise, users of EHRs and other health IT, and some of us who have been working around data sharing. I would like to emphasize our deliberations on this criteria. Technology is important, but it is also insufficient. This is really about sharing the data freely and effectively across sites. And many of the barriers to doing that are not technology barriers. They are business or otherwise. So I think it will be very important, particularly as we move to measures of population health, and also to reduce the burden on providers, that this data be shared effectively, regardless of the technology.
So you have, of the 20 or so models you have under review, can you provide some examples of those that are leveraging technologies and have the providers come up with creative solutions?
So there are several that have been highlighted that we have reviewed already. There is one specifically around looking at 5 different cancers and accuracy of diagnoses, lung, colorectal, breast. It's a bundled payment model. It comes from the Hackensack Meridian Health. They have a special technology that looks at the biopsies themselves and is able to do genetic analyses and helps tailor the treatments to the specific characteristics of that particular tumor type. We talked about the proprietary nature of that technology, and they've assured us that other systems can adopt either that technology or a sister technology like that. But that's just one example.
Right. Sure.
There are several others.
Gentlelady's time's expired.
Thank you. I yield back to, thank you.
Gentlelady yields back. Chair recognizes himself for 5 minutes. I want to say at the beginning of my question period that I'm not an expert on this, and I didn't hear the opening statements. So if this were an energy hearing, I'd be in good shape. But talking about MACRAs, as I told Gene Green, a little out of my depth. My first question is just a basic question. We wanted to change the payment system because the old one was so complicated. Are any of these new systems actually being used right now, or are you just thinking about it? Either one of you.
The models that we have received, several of them we have recommended for further testing, but then it is up to CMS and the Secretary when and if to implement those. So
as we speak, all the payments are still being made under the old system. Is that correct?
Well, there are demonstration projects that CMS has implemented over the last several years that do change payment, but the physician-focused payment models that we have evaluated have not yet been implemented, at least through CMS.
And Dr. Burgess told me that you've actually voted on 5 alternative systems. Is that correct?
Yes. Yes, 5. We've deliberated on 6, voted on 5 with recommendations to the Secretary.
Okay. Now, these 5 all passed, so to speak, so they have been forwarded to the Secretary, or did you vote down any of them?
We voted one down, 2 down, and then the reason we deliberated on 6, the 6th submitter retracted their proposal after hearing the point of view of the committee. They resubmitted it after they've modified it, but the others were either recommended for small-scale limited testing or implementation.
So you forwarded 5 to the Secretary,
yes,
which we don't have right now.
That's correct.
But there's somebody acting, I guess. The Secretary or his or her designee decides if these systems that you voted on are acceptable for the marketplace. Is that correct? And then if he passes it, then it comes back and doctors pick which one they want to use? Is that how it works?
Well, that is part of our challenge, is we see this, we want to be a value add to the system. We're upstream of CMS and CMMI. We want to make sure that the process and the evaluation and the analysis that we're providing sharpens these models so that when they get downstream to CMS and CMMI, it helps them do the work they need to do relative to analysis and figuring out how to actually stand up these models within the current Medicare system.
That, to me, that seems overly complicated. Now, it may not be, but I want to try again.
Well,
somebody's going to, your doctor groups have voted on systems that they want to use, right?
Right.
You have forwarded those to the Secretary of Health and Human Services. Secretary of Health and Human Services and the bureaucracy decides which of those are acceptable. Isn't that right?
That's right.
If they say, we've got the HHS stamp of approval, it comes back, and who decides which of those to use once they're approved?
Well, the only requirement is that the Secretary post a public response to our recommendations. It is then up to the Secretary and CMS if and when to implement.
Right. Our charge is to advise the Secretary, work with the stakeholders, make a recommendation, provide that advice.
I got that, and you've done it.
Yes, sir.
You're waiting on the Mount Olympus approval, right? When that sooner or later, some of these are going to be approved. My question is, once they're approved, I guess I'll rephrase it, how are they implemented once approved?
And again, that is, we need more clarity on how that's going to happen. That's not under our purview. We are ready, willing, and able to partner with CMS and CMMI.
Well, who's the decision maker?
Secretary and HHS.
Okay, I'm saying they've approved it. I mean, at some point in time, somebody in the system, a doctor who's seeing patients, says, okay, we're going to switch from this old system to this new system A. And I'm assuming, since we're trying to be inclusive, that it's a hospital, a region, a state. Yes. Somebody says, yes, we're going to use alternative system A.
Right. So that's where, just like in CPC Plus, or some of the other models, that alternative payment models that are already been deployed, the oncology care model, for example, that's what CMS will do. They will take our recommendations, they'll look at these proposals, they'll refine the model and figure out how do we build this model with these concepts and be able to implement it within the Medicare payment system. They will put it out there, I believe. I don't want to speak for them, but my guess would be that they'll take these models, put them out there for the physician, CMS and Medicare, put an alternative payment model.
So CMS is the one who chooses which model to use?
We don't have the authority to direct CMS to do that. We can make recommendations.
So they're going to tell you which model to use? See, I had it all wrong. I assumed the doctor groups, the providers, would choose which one they want. But you're saying CMS is going to say, we like this one.
CMS will make the models available for the stakeholders to then sign up to deploy. So they will, just like the oncology care model, it is out there, and practices will sign up to participate.
And they can make more than one model available?
Yes.
Yes.
Okay. Because I thought the whole point of this was to give doctors, or provide, I keep saying doctors, to give providers, well, maybe Mr. Buchan.
Well, the gentleman,
I'll be happy to use.
I think what you're trying to get at, if there's an alternative payment model that's been approved and you don't participate in that, then you're in MIPS.
Right.
I mean, you can, at that point, it seems to me you're not necessarily forced to accept the alternative payment model, but if you don't, you have to participate in MIPS.
What's MIPS?
That's the overall reporting system that assesses quality.
The current
value.
The current.
Well, no, it was put in place under MACRA.
So it's a new one too.
It's a consolidation of 3 separate evaluation systems that were
I'm
previous.
glad I have clarified
MACRA.
this situation.
So the point is I think, Chairman, is that a physician, if they don't participate in the alternative payment model, they will have to be in the MIPS, and you might comment on that.
This is
I
the
yield back.
last, because our time's expired, so answer Dr. Busson's question, and then we'll go to Ms.
I just want to say,
Castro.
Mr. Chairman, you and I can talk energy all the time.
Yeah. Energy policy is simple compared to this. Would you like to comment on?
Yes, that is correct. PTAC is actually, I think our role is to expand the options for participation so that CMS has a broader portfolio that is representative of what physicians think would be better models. So we can recommend those for inclusion in the Medicare portfolio, but again, it's not up to us who participates or if they're implemented.
We thank and we yield to the gentlelady from Florida for 5 minutes.
Well, thank you, and I want to thank you, Mr. Chairman, for calling this much-needed hearing, and thank Dr. Baylett and Ms. Mitchell for your work on the Physician-Focused Payment Model Technical Advisory Panel, and to all of the doctors and medical professionals that have also been engaged in this and taking this on. I'm very gratified to see the progress on transitioning from to value rather than volume. At the same time, while we improve patient care, allow doctors to practice medicine, and do everything we can to help lower the cost. I hear you talking about the difficulty now with submissions and approvals, and you need answers from CMS and CMMI. Would you say that the progress has stalled on your work?
I'm not sure I would use the word stalled. I think we're new. We're new at the game, and I don't mean game in a negative way, but I mean this is a new process. We've only sent 2 sort of series of recommendations to the Secretary, and as you know, we have an interim Secretary, so I think that people are finding their way. We are in dialogue with CMS and CMMI. It's a constant, it's a constant partnership. We're trying to work with them. They're providing insight and
so it would be helpful if the committee held a follow-on hearing with CMS and the folks that are working on this to get some of the answers that Mr. Barton asked, and Mr. Green and others. In order to most effectively review the proposals submitted to PTAC, MACRA required the Secretary to establish a set of physician-focused payment model criteria for evaluating the proposals. MACRA also required PTAC to then review proposals submitted based upon these criteria when making recommendations to the Secretary. So there are 10 criterion, including the extent to which proposals provide value over volume, increased care coordination, improved quality, all factors that PTAC considers when evaluating a proposal. Ms. Mitchell, can you describe the 10 criteria established by the Secretary, particularly the criteria designated by PTAC as high priority criteria?
Certainly, and if I might just respond very briefly to your last question, I think it is very important. We are not seeing any sort of slowdown in number of submissions to the committee. In fact, it's the opposite. We have more proposals than we had even anticipated. I think the question about what happens next is really the open one.
Thank you for clarifying that.
Yeah. And in terms of the high priority criteria, we are evaluating each proposal against every criteria, but there were certain criteria that the committee thought carried particular weight. So as an example, scope is a high priority criteria. We don't think that it's optimal to identify a model that only 1 or 2 or just a handful of practices can participate in. We are really looking for more transformative models. So scope, as an example, meant that we would have greater participation if it was a high-value payment model. Which were the high-priority criteria, quality and cost. Obviously, the point of payment reform is not to change payment, it's to get better care at lower cost. So how are we determining if these changes are actually giving better patient care at a more affordable rate? So that seemed extremely important in the entire undertaking. And then finally, payment methodology. If Dr. Berenson was here, he would tell you we are not just looking for an addition of a new code. We are talking about meaningful changes in the methodology of payment. And that is what we are seeing. We have had some proposals that do not meet that criteria. They could be fixed differently, the barriers. We are really looking at models of payment that are currently not supported and require a new payment methodology.
So, Dr. Baylett, you talked about, you've seen some innovative proposals. Give us some hope here. What's innovative that you've seen? What's been difficult? What's been a little less challenging?
So there was a lot of energy at our last public meeting when we looked at hospital at home. So typically patients today show up in the emergency room. They need admission. They have criteria to meet admission. And this model has the sophistication for select patients to actually treat them as if they were hospitalized, but to provide that care in the home. That is tremendously innovative. It is also allowing patients
Is that because the medical professionals go there? I mean,
there's a team that's deployed, there's training, but the point is that hospitals are not places, I'm a surgeon and I would tell my patients, you want to be in the hospital no more than 1 second longer than you need to be. Bad things happen to you in the hospital. And so this allows patients with the patient and the family to make a decision to get that care, but get it at home safely. We think that model shows tremendous promise. There's some economics, obviously, but it also is very beneficial when you match it against the criteria. It helps the patient specifically and their family to be able to get that care at home. That's just one example of several of the models that we've looked at.
So out of these models, what's been particularly difficult?
Physicians and stakeholders are they're much clearer on the clinical side of the model. Where we're challenged is on the payment side, getting the data to be able to model for the committee to say, here's what the data is showing us, here's where the dollars are, and here's how the model will impact the dollars. That's an area of technical assistance that could help, and I think Elizabeth wanted to make a comment.
I would just add several of the models we've seen are community-wide. As an example, how do we bring in hospice care, transportation, other services that patients actually need? And there is a major barrier of sharing data and information effectively in a timely way. So that, and a provider has said that that is their primary barrier to implementing the models that they're bringing. So that continues to be just a priority area that we've got to solve.
Great. Thank you again for your work.
Thank you.
Chair thanks the gentlelady. Gentlelady yields back. The chair recognizes the gentleman from Illinois, Mr. Shimkus, 5 minutes for questions, please.
Thank you, Mr. Chairman, and I appreciate my colleague from Florida, because that's where one of the questions I was going to ask, and she picked it up, was highlighting a specific example, and I think you outlined a pretty good example of where you could be helpful. I'm interested in this is because, I was here in '97 when we passed the SGR to spend my career postponing it to the point where then we got to MACRA and MIPS and all this other position where we are today. Being a competitive market Republican and understanding competition and how that improves, you always get a little concerned. The government is such a big payer in the healthcare arena, whether it's Medicare or Medicaid, that we really do we drive that reimbursement. We drive the reimbursement because, actuarially, those two are mandatory spending programs that are actuarially challenged. So then how do we look at trying to save the money? But we know docs want to get paid, right? We know docs want to get paid well if they can. So I think this is an interesting debate because doctors still want to be compensated for their training, their loans, and the like, while we're trying to drive efficiency and lower costs. And that's your challenge. And you're an advisory committee or commission, and you're advising the federal government on how we might be able to do that. And you gave us an example of one just in the last testimony. But I'm concerned about you talked about telemedicine, sharing data. Part of that is proprietary information. Part of it's going to be
patient records. Part of it's going to be specific care models that practitioners may want to say, this is how I can financially do it. This will drive patients to me, but that gives me a competitive advantage, right? So how you doing this? I mean, how you, or just let's do it in the big data framework. Big data, and thank you for help me remember the word, an algorithm. I mean, and we're gonna have these big discussions on algorithms and how do you do transparency on algorithms when someone feels that that's a proprietary nature that they've come up with? So those are the questions I'm interested in hearing as you're trying to provide advice and counsel, because some of this stuff might require either proposals from HHS or maybe legislative changes.
Yes.
Can you guys, Ms. Mitchell, you want to say anything based upon my little diatribe?
I will try. We have actually had proposals that do include proprietary elements, and I think we have been clear with submitters that anything that is included in a proposal for Medicare, they won't have proprietary elements that couldn't be shared more broadly. Again, this is an entirely voluntary process. They could do this without Medicare as well. I think it would be helpful probably to ask the next panel about some of their experience with that. And I think it's going to be a balance of interests. I think given the massive investment that we put into our healthcare system and the value for patients we're trying to achieve, I think there's just going to have to be a balance of obviously preserving the interests of all. I also think that there are success stories around the country, Oklahoma, Oregon, others, where they are sharing data across the community in a way that protects privacy. They are clearly effective stewards of that data, but it also allows physicians and others to have a full picture of population health and patient care. And frankly, it helps with patient safety. If a patient is admitted from one hospital to another and those records can be quickly transferred, that actually helps patient safety as well. So there are ways that this is being done around the country now that could be emulated and scaled.
Yeah, I appreciate it. And I think also just and I'm going to close with this brief statement is, I mean, there is a national debate about how we pay for health care. And will it be a one-payer system, or whether it be a competitive market model that helps bring clarity and efficiencies? So good luck. I'm not sure how it's all going to turn out. I yield back the balance of my time.
Chair thanks the gentleman. Gentleman yields back. The chair appreciates the gentleman's request for good luck. Chair recognizes the gentlelady from California, Ms. Eshoo. 5 minutes for questions, please.
Thank you, Mr. Chairman, Dr. Bailey. It's wonderful to see you, and thank you, Ms. Mitchell. I have really enjoyed the questions of members and your responses, because you keep deepening and broadening what you're doing. Several of my questions have already been posed, but I want to pick up on what Congresswoman Castor said and recommend to the chairman that we have another hearing both with the stakeholders and with HHS. Because I think it's important to bring that, to strengthen the linkage, since you are dependent upon you're doing so much work, and then it goes someplace else, and it seems to me that there's a question mark around it. So I'm not suggesting, I'm not impugning the agency. It just seems to me that I don't have a sense of how welcoming they are, especially if the model that you are recommending to them is going to cost more, because there's a constant push on the agencies not to spend as much. So, which takes me to a question. You know the area that I represent. It's known as the innovation capital of our country. Most people think of it as just in terms of technology, but we have many biotechnology companies that are creating really innovative technologies. Stanford Medical Center, I think, is doing important and exciting work around telehealth and telemedicine for the treatment of other health conditions such as stroke. Specifically, how are new and innovative technologies being integrated into the APMs?
We've had several proposals that have proprietary technology that are embedded, and I gave one example relative to the genetic ability to screen the tumor types for personalized medicine, and I believe Stanford is trying to do that work as well. There are other information systems, population health systems that are able to look at the entire cohort. If you're in, for example, renal disease, look at your patient population and find elements to help sharpen the care and offer patients treatments before they start dialysis to improve the outcomes and decrease the chances for complications. I'm trying to remember. I have all of the 20 in front of me.
That gives me a flavor. Do you know what the cost of a particular application is after you've reviewed it?
No, we don't. No, we don't.
So that's up to the agency to cost it out.
Yes.
Mm-hmm. And our providers, money drives everything in the world. I'm sorry to say, but it does. I don't know what the incentive on the part of physicians would be. Well, maybe some that are highly idealistic, but people have to live, to move away from fee-for-service. I think doctors would say, and what do I get out of this? And I don't think that that's a selfish question. So do you see in the models that have been submitted to your commission that, I don't know how to put it, are they based, if you put your fingers on the scales, is it with anticipation that there will be a better system with better money? Maybe that's the best way to put it.
Physicians, they want to do the right things for their patients. Mm-hmm. They want to get recognized appropriately for the work they're doing. There are certain limitations in the fee-for-service system that doesn't recognize those efforts.
Right.
And despite those challenges, physicians continue to do it anyways. Mm-hmm. Okay? These models reframe the way care is delivered. It recognizes their efforts. It pays for nurse coordinators. It pays for home care. It pays for things that the traditional system doesn't recognize that are incredibly valuable to drive outcomes and lower cost. So that's certainly why I'm energized to be in this work, and I think my colleagues on the committee would echo that, and you'll hear that from the stakeholders who are behind me. Physicians, again, and clinicians, they want to do the right thing for their patients. And yes, the economics have to work, but there also has to be, you have to do the right thing for your patients, and it can't be completely driven by the economics. But we also have to be realistic about that.
Thank you very much for your important work. It's up to the chairman. You can answer. I can't talk.
Please answer.
I would just add that I think all the research, including recently from the National Academies of Medicine, show that about 30% of health spending do nothing to improve patient outcomes. So there is waste in the system that could be addressed through better, more effective utilization that does not in any way create barriers for physicians. Physicians are trying to navigate those barriers right now. I think there's huge opportunity. I think there was a recent GAO report that showed we're spending about $40,000 per physician per year on performance measurement. There are opportunities for savings that actually enable physicians to have more flexibility to give the right care at the right time.
Thank you very much. Thank you, Mr. Chairman.
Chair, thanks, gentlelady. Gentlelady yields back. Chair recognizes the gentleman from Missouri, Mr. Billy Long. 5 minutes for questions, please.
Thank you, Mr. Chairman. And my questions are for both of you. And Ms. Mitchell, I'll start with you. And this first one might sound like an oxymoron, but can you each elaborate on why it is important that physicians not over-assume risk in models they may be approaching for the first time, while at the same time keep pushing forward in their drive for physicians to assume risk?
Well, certainly, I think if Mr. Miller were here, again, representing the, the committee, I don't think risk is magic in any way. I don't think the assumption of risk will suddenly change care delivery, but I think it is a move towards greater accountability and ownership for outcomes. I think what we're trying to do is find models that appropriately enable risk and accountability, certainly without putting a burden that is not manageable or sustainable on physicians. So I think it's a very important balance. I don't know if that answers your question, but we think it moves them towards value.
So to follow on with Elizabeth's comments, there are unintended consequences. These models have elements that are new. Many of them have not been field tested, if you will, so the intent is good, but until you actually deploy the model in the field, you're not exactly sure what are the outcomes. Are you going to get the outcomes that the model was established to accomplish? Which is why the committee felt strongly and continues to feel that limited testing is necessary for some models where the elements are uncertain or unclear. So we need to strike a balance between encouraging physicians and clinicians to take risk and to be held accountable and to be recognized for outcomes and paid accordingly. But we also know that in the world of in the past with managed care, if you push too fast, too far, and you outstrip the sophistication of the clinicians and their ability to perform, those are also unintended consequences that we need to be careful about, making sure that we don't do anything that's so disruptive that it impugns these organizations. And I used the word vibrancy earlier, and I use that specifically. I hear a lot of things about, well, we want to keep our practice viable. I used to run a practice of nearly 2,000 physicians in Wisconsin. I don't think viable is what is top of mind for patients who are seeking care. We want physicians and clinicians to have vibrant practices to be able to provide the highest quality care with the best outcomes. And that's where, if you outstrip your ability to do well in risk, you can have an economic consequence that could impugn your practice. And when these small hospitals and rural practices go out of business, your ability to repair them or replace them are incredibly hindered. And so that's where I want to make sure that as we go forward, we're very thoughtful about implementing at the right pace, in the right way. And there needs to be flexibility. Elizabeth said it's not a one-size-fits-all solution that we're talking about here.
Okay, and since your microphone's still on, I'll start with you on my next question, and then we'll move to Ms. Mitchell. I'd like for both of you to answer this one. But do you believe CMS's approach in the short term should be more focused on ensuring providers are ready to transition to qualified alternative payment models, or in simply getting more providers into value-based payment arrangements?
You told me earlier that you were gonna give me a tough question.
No, I didn't.
Yes,
you said
you
I was. I just agreed with
well, I think, and I'm not being evasive, I think it's both. I think physicians, as I said, physicians are indifferent and clinicians are in different states of readiness, and so they need to get in. They need to move away from fee-for-service, whether they get in on the merit-based incentive program, which has value elements, or they're sophisticated enough or willing to get into an alternative payment model. I think physicians have to get on the playing field, clinicians have to get on the playing field and get in the game. And the fee-for-service model is not sustainable. And so I think this legislation, these efforts compel physicians and clinicians to get on the field. Elizabeth?
I would just add that what we are seeing in PTAC is the early adopters, the leaders and the innovators who are ready to go. And I think by creating that opportunity, by allowing them to go first with appropriate technical assistance, flexibility, and small-scale testing, we will learn a lot, and that will enable some of the practices who are less ready to actually, I think, succeed as they move forward.
So do you agree with the doctor that both are important?
Both are important, yes.
Okay, thank you. I've got a really, really tough question for my next one, but you all are lucky I'm out of time, so I'm going to yield.
Gentleman's time has expired. Chair recognizes the gentleman from Maryland, Mr. Sarbanes.
Thanks, Mr. Chairman. Thank you to the panel for being here. A lot of the motivation for the Affordable Care Act was to begin to kind of turn our healthcare system towards prevention, primary care, shift the kind of caregiver world to the prevention side of the spectrum, et cetera. MACRA was passed separately from the Affordable Care Act, but I'm curious if you perceive that there's alignment there between the goals of the Affordable Care Act and the goals of the new kinds of payment methodologies that MACRA is pursuing.
Well, I guess I would say that to the extent that the goals of both legislation were affordable care, I think there is alignment in the intent. Obviously, the Affordable Care Act focuses more on insurance, and I think MACRA focuses more, and appropriately so, on the fundamentals of care and payment. I don't think you'll have affordable insurance until you have affordable care, and it is going to be these payment and care delivery reforms that actually enable that.
Thank you. The other question I had is, it gets to sort of how, and a number of members have spoken to this, but how the physician community in particular is receiving these new models. And I don't know if you're the right witnesses to describe this, but I'm interested in whether kind of the next generation of physicians coming along, whether you're seeing that there's, first of all, more facility with the concepts, maybe more eagerness to try them. Are medical schools beginning to assimilate some of these models into the conversations they're having with the next generation of providers? Is there asymmetry with how certain cohorts within the physician community are responding to these things?
I think it's highly variable, and I'm hoping that my colleagues, when they come up and testify, that you'll hear some specific answers to those questions relative to training and the receptivity for the next generation of physicians and clinicians to embrace these models and care delivery. I think, and I don't want to speak for the committee, but from my own personal experience, I think there's an appetite for new medical trainees who are coming and entering into the clinical practice. I think there's an appetite for them to provide the value, which is the high quality and affordable care. I think they understand the economics. These folks are coming out of school, for example, with hundreds of thousands of dollars of loans. So I think that they understand that there's an economic consequence if their current employer or their practice is not successful. So I believe that the economic piece is there. I think the clinical piece is there as well, relative to innovation and training. And I think there's a willingness to try. I think one of our biggest challenges is there is still the unknown. We don't know how some of these models are going to impact outcomes, and so I guess I'd leave it at that. So,
do you feel as though the provider community gets that they're living in a new world, if you think they're living in a new world, or not yet?
I think there are, I think there's probably some vestiges of remnants of folks in the provider community that still harken back for the fee-for-service environment. And I'm not saying that fee-for-service, there's not a place for that model in the new world. But I think that also there's a high degree of recognition that the value, paying for outcomes, being able to track it and being able to actually deliver on the commitment to provide outcomes is one of the things that's in front of us that actually can bend the cost curve. So I do think that that's where the collective thinking around the provider community is today. As I go around the country, I don't hear a lot of debates about, well, we need to go back to just pure fee-for-service. I'm not hearing that. I think people are now focused on what does it look like, how do we get there, and at what pace do we move from fee-for-service to value, and how do we do it while we are basically practicing in both worlds? How do we navigate risk in one and fee-for-service in the other, for example?
Okay, thank you. I yield back.
Gentleman's time has expired. Gentleman yields back, and speaking for the vestige, Chair recognizes the gentleman from Indiana, Dr. Bouchon.
Thank you, Mr. Chairman. I would like to comment on what Ms. Mitchell said about the cost of care coming down as the key to affordable insurance. I completely agree on that. That's a big issue. And to do that, more transparency in the healthcare marketplace, as well as more active consumer participation in their healthcare decisions, including where the cost of what they're being provided is really key. As a former cardiothoracic surgeon, I know my organization that I participate in, the Society of Thoracic Surgeons, they've been really pioneers in quality measurement for the last 25 years with the STS database. And Mr. Chairman, I'd like to ask unanimous consent to submit their comments on this hearing to the record.
Without objection, so ordered.
I'd like to highlight the STS is designed a quality-based payment program specifically related to cardiothoracic disease, including coronary bypass grafting, valve repair, replacement procedures, and as well as treatments for lung cancer, relying on this database. And I'd encourage CMS and Congress to take a look at that, as they already have. And they're actively pursuing partnerships, looking forward to bringing, fruition a payment model that could help provide quality incentives and efficiencies to really one of the largest cost centers that we have in the Medicare program. Ms. Mitchell, according to CMS, only currently 5% of physicians are in alternative payment models. And I've heard from a number of physician specialty organizations that there are some stark law barriers potentially to participating and succeeding in an APM because it prohibits practices from financially incentivizing their physicians to follow treatment pathways that are related to value that might improve the system. Do you think there's any problems there legally that are preventing some people from participating in APMs?
I am not an attorney and would not want to pretend to be, so I would not be able to answer that question with any authority. Perhaps Dr. Bailett has insights.
Yeah.
No.
Maybe I'll ask that from
Played one on TV.
the next panel. There are some barriers out there. I'm not a lawyer either. But we're going to be working on trying to decrease the barriers for physician participation in APMs. And maybe any one of you can discuss the importance of engaging the specialty community in developing APMs. That can be some of the more difficult APMs to work to get together. And can you elaborate on where you see growth potential in the future for specialists playing a bigger role in these new care delivery models? Dr. Bailett.
Well, we've garnered a lot of interest from the specialists. Single specialty societies, you're going to hear from my colleague, Dr. Opelka, about his ACS model. So there's tremendous interest, and we've got a number of specialty-specific models that we're evaluating right now. I think that our interaction with the specialty community actually is pretty robust. But again, I think you'll hear that as you get to the next panel.
Yeah, I suspect that's true. Is it more difficult? Do you think it's more difficult to put together APMs as it relates to the specialists versus primary care, or no?
I haven't seen that.
I haven't seen that either.
Not really?
No.
Okay, good. The other area, and I have a minute and 30 seconds to address in MACRA, is will require significant guidance by CMS's physician participation in multiple APMs. Obviously, want physicians to be able to experiment with different approaches to improving their practices while also recognizing that many APMs being developed by stakeholders are somewhat narrow, centered on a specific disease or condition. Can each of you speak to why it's important to allow physicians to experiment with different quality payment-based payments? And have you thought about this facet of the program as you review the proposals?
So I'll try to answer that. I actually think it could be very important to participate in more than one model. I think at the community level, you're trying to align models and incentives and not carve out certain groups over here and others over there. So I think the ability to, as an example, have episodes within a capitated payment or an ACO, I think is an important innovation to test. I think there are regulatory barriers right now to doing that, and I think that is something that warrants further exploration.
I agree. Yeah, no.
I yield back.
Chair thanks the gentleman. The gentleman yields back. Chair recognizes the gentleman from Massachusetts. Mr. Kennedy, 5 minutes for questions, please.
Thank you. The chairman, thank you for the witnesses. Thank you for answering the questions and engaging the discussion. Wanted to get your opinion on a couple of things and build off a little bit of the conversation from our colleagues. There are a variety of alternative payment models that have now been put forth and authorized by CMMI. In your assessment, if you had any ideas or suggestions for us, how does CMMI evaluate those different models? Are there factors there that should be taken into account differently, or aspects there that perhaps Congress should be looking at that should be accentuated that aren't fully contemplated there? Do you have any suggestions as to how those models or other models might be put together to address the themes that you've talked about so far today?
I hope this answers your question. I think that there are a lot of lessons from the demonstrations to date. I will point to sort of CPC and CPC Plus initially, because we have seen, I think, real success in some communities because you have aligned payers. So you have alignment of incentives and measures. So it's not just noise, it's everyone's going in the same direction. It is a primary care-based model, and it requires data sharing across the community. I think those examples point to successes that could be replicated. I think there are some elements of the CMS evaluation approach that I don't know that we get information soon enough so that we can apply it and sort of rapidly learn and improve. And I think there are ways to really take lessons earlier and share them more effectively to benefit all of the new models and implementers. Jeff, would you add anything?
Yeah, no, I think that's well said.
Building on that for a second, then one of the areas that I've focused on here is mental behavioral health and the integration thereof in primary care. So particularly for that model, then we've seen issues around the absorption of electronic medical records for mental health practitioners, the sharing of that information between primary care and mental health practitioners, and obviously concerns about the dissemination around mental health records. There's some things that CMS might be able to do there. There's some issues there that actually might require a legal change. I don't know if you have any suggestions for us to look at, given, at least in my concerns, about the lack of adequacy on a comprehensive care system set up to address those patients that are suffering from mental illness across the country, particularly with regards to Medicaid. And so I don't know if you have any comments on that, but would welcome them.
I would personally just state for the record, I think that is one of the highest priority areas in the country. I think that if we don't address mental and behavioral health, we are missing just a huge need, and integrating that effectively into primary care is a very important strategy. I think there are very real limits and barriers, some regulatory and legal, that keep us from sharing information adequately. And I think there are also examples around the country where we have done that effectively, responsibly, and protecting patient privacy, but actually getting the information to people who need it for better care. I'm happy to follow up with you on some of those models, because you're exactly right, we have to address that.
Doctor? Anything else?
No, I agree.
So one of the great things about representing Massachusetts is I'm kind of preaching to the converted here, but being able to visit particularly those community health centers that are on the front lines of some of these issues, from partnering with farmers markets and doctors writing scripts to farmers markets to make sure that their patients are getting access to fresh fruits and vegetables, to the absorption of medical and adoption of medical legal partnerships, so that when a patient potentially comes in with an asthma issue, that if there's mold in an apartment, yeah, you can give them an inhaler, but you're not going to address the concern because there's mold and an inhaler doesn't cure mold. Are there other systemic, you're talking about aligning those incentives, what should we be focused on when we start to look at issues? You mentioned transportation before, which is obviously critical. Are there other kind of one-offs here that you think we should keep in mind as we try to think of the opportunities and challenges of actually trying to reach out to patients and then wrap them in this continuum of care so you can get to them and reduce the cost of delivery?
I think there are lots of opportunities, like palliative care, for example. I mean, I think that the data where, you follow the economics. So we consume a tremendous amount of resource relative to folks who are at their end of life. We have been able to, I've seen models out there where we've been able to get the uptick, the average length of stay, for example, in hospice, which is, I think, nationally somewhere between 16 and 18 days. There needs to be a more concerted effort. That should be measured in months, not days, if we're doing the good work and want the outcomes we would want for that cohort of patients. So I think there's tremendous opportunity. And I use palliative care as an example, but there are others that you also raised.
And you're exactly right. That's where the opportunity is to really improve health and reduce cost. We have examples, my members around the country, their partnerships with the criminal justice system and hospitals to actually identify much more effective interventions than another ER visit. And by doing that coordination, finding out what people's real needs are, typically housing, transportation, the real upstream social determinants, that's where you're going to really impact health. And connecting those services, the providers, and that information, I think is a very big opportunity.
Thank you. Appreciate it.
Thank you. The gentleman yields back, and I'll now recognize myself for 5 minutes for questions. Dr. Pallone, in your testimony, you mentioned how Medicare is driving market change through the development of APMs. What are these trends, and what are you seeing the impact is on other players, or payers, I'm sorry?
Well, I can speak for my organization that I currently work with, Blue Shield. We are moving the commercial side of the business to value-based pay for value. It is one of our top priorities in the organization. And MACRA actually allows, in 2019, allows the commercial payers to partner with Medicare and put these models in the field. Again, the economics, going from fee-for-service to value, paying for outcomes, it not only is the right thing to do clinically, but it's also the right thing to do economically. And as one of the largest payers in the state of California, contracted with over 50,000 physicians and over 400 hospitals, we are very activated to get these practices of the future, if you will, out in the field. And we want to do it with the stakeholder community, not to them. And that is one of the things that is a tenet of the PTAC, which is why we're so transparent. We want to make sure that we are right there, lock arms with our stakeholders, and I hope you hear that from the folks who are going to come behind us. But it is driving market change.
Do you believe patients are being affected in a positive way with this?
I do. Yes, I do.
Okay, thanks. I'll have another question. So it appears that many are already responding to practice and transformation efforts in commercial markets. Can you speak to the ideal way Medicare can both learn from these private sector efforts and harmonize with them to smooth practice modernization?
I guess I would just say I don't think providers think about their patients based on who pays for their care. So to the extent that private and public payers can align, that will enable providers to actually give optimal care across their patient population. To the extent that there are innovations in the commercial sector, I would hope that they would share those. Often it's very hard to get information on the outcomes of those changes. I think they could inform Medicare, and I think Medicare coming to the table and joining multi-payer efforts is really an optimal way to accelerate change.
Okay, thank you. And can you comment to the interest PTAC and the diversity of models, but also those who have reached out to you? Do they include large and small, rural and urban, as well as primary and specialty interests?
Yes.
Specialty interests, not special interests.
Yes, and so I think you'll hear we have a small rheumatology practice that has submitted a model before us. We have not evaluated it. It's under evaluation. So we have a broad array of clinical stakeholders, again, from the range of small and rural practice to sophisticated systems and specialty societies like American College of Surgeons, for example.
Okay, thank you. I will yield back and recognize Dr. Ruiz for 5 minutes for questions.
Thank you very much, Mr. Chairman, and thank you for allowing me to wave on to this subcommittee. When we passed MACRA in 2015, one of the goals was to increase quality of care and stabilize payments, moving towards payment models that reward high-quality care. One of the options under MACRA is for providers to participate in an advanced alternative payment model under which the physicians accept some of the financial risk. However, in just over a year since its creation, the Physician-Focused Payment Model Technical Advisory Panel, which reviews the proposed APMs, has received only 19 proposals, as we've discussed earlier, for consideration, deliberated on just 5 of those. So I'm concerned we're not seeing enough to really make a smart decision on what's going to be the best model. And speaking to different physician specialty organizations, I've learned that one of the greatest barriers to developing APMs are laws that prohibit many of these physician practices from coordinating and collaborating with other specialties while they are trying to develop an APM, much like what Dr. Bouchon mentioned. So this means that the groups are not able to test out their model to see if it will work in practice. And while these laws are important and serve an important purpose, in this instance, they are restricting the development of these payment models, stunting movement towards fully achieving the goals of MACRA. So what are some of these barriers in general that have inhibited different practices and organizations from developing APMs? If you can name me the top 2 barriers, and then I want you to name if you were to recommend us, how would we resolve those top 2 barriers? Start with Mr. Bailey, and then I'll go to Ms. Mitchell.
I guess what I would say, I would turn to the second row of testimony behind us, the folks who are actually out there trying to create these models for our consideration to answer your question relative to those 2 barriers.
Okay. Ms. Mitchell, do you have an answer? Or an idea? Because
Well,
I will ask them, and I've been speaking with them, but I wanted to get your perspective in being involved as well.
Absolutely. In my testimony, I shared that the barriers that we have heard most frequently in our first year are access to data and technical assistance to design the models and opportunity for small-scale testing. So I think those are 3 issues. We've actually asked for congressional consideration on each of those. So I do think that there are barriers, but I do also think that the panel, the next panel will be able to share how they have overcome them.
Yeah.
So the Secretary so MACRA required the Secretary to establish a set of physician-focused payment model criteria for evaluating proposals. MACRA also required PTAC to then review the proposal submitted based on these criteria when making recommendations to the Secretary. These 10 criterion, including the extent to which proposals provide value over volume, increased care coordination, improved quality, etc. Can you describe the 10 criteria established by the Secretary, particularly the criteria designed by the PTAC as, quote, high priority criteria?
Yeah, we reviewed that earlier, but we can go back again.
Give me the top 2, please.
There's 3.
Give me the top 2.
Scope, cost, and quality.
Scope, cost, and quality. And in the proposals that you have reviewed in scope, cost, and quality, what are the easiest criteria for most proposals to attain?
Well, I think all of the proposals that we have seen have recognized that we are looking for models that improve quality without increasing cost, and they have all brought forward models that will hopefully...
So everybody has been able to meet all 10 criteria easily?
No.
No.
All right, so which are the difficult criteria for the organizations to meet?
Well, I think one of the challenges is sometimes that it is not a payment methodology that is actually different enough to require an alternative payment model. As an example, they may just need a tweak in codes or something, a much more minor intervention. So it might not qualify as an alternative payment model. That's one example.
I would say another example that we've found as a committee is the care coordination, the ability for physicians and clinicians to work with each other across communities, across disciplines, sharing data that we talked about. Those are all contributors to make.
Is it more of a technical difficulty with the electronic medical records issues, or is it a cultural difficulty within different institutions?
I don't believe it is a technical barrier. I think it is more often a business or a cultural barrier. I think that it is certainly possible to share data across platforms. And
what would you recommend we do to improve collaboration across the different institutions and specialties so that we can get better models?
I think that we are seeing that. I think the proposals that are coming forward are actually laying out ways to collaborate more effectively. I think that there can be incentives for data sharing. You can have data standards so that it is possible to share data across platforms, and you could actually ask the vendors to ensure that there is no data blocking so that data can effectively be shared.
Okay, if the barrier is a business model, then I think we have to look at what are the business incentives for them to work together during these APMs, because they also have business needs in the short term as well.
Absolutely, and I think that by changing some of the incentives, that we're actually helping them to find viable business models for the right care.
Gentleman's time has expired. Chair recognizes the gentleman from Oklahoma, Mr. Mullen. 5 minutes for questions, please.
Thank you, Mr. Chairman. Thank you for both of y'all being here. As you guys have been sharing the same questions, my question line will be the same too, and really appreciate y'all's patience. As you can tell, the committee is really looking into this. This isn't something that we're looking to stand in the way. We're looking to help to improve, and so we appreciate you all being here. I represent a very rural district, very, very rural district, and our constituents obviously receive care from, many of them, from critical access hospitals. Do you think it's time that we explore target value-based payment models for critical access hospitals that recognize the unique needs of rural areas?
Yeah, I think, yes, I would agree with that.
Ma'am?
Yes, I think so. I think there can be some very innovative practices in rural areas. And in many cases, some of these models may actually allow small rural practices to succeed by creating more flexibility and really evaluating.
Which models specifically would you think?
In terms of the models that we've received?
Well, and if you're talking about ways to look at the value-based payment structure, how would that look like? What would we be needing to push from this point of view to make it?
So my experience with critical access hospitals in small rural communities in my former practice was in Wisconsin. Getting specialty care to these small hospitals, allowing patients to get the care they need at home or in their local community rather than have to travel great distances. So using technology, telehealth, telepsych, for example, psychiatry, behavioral health at the bedside, neurology, it's often difficult to get those services, the actual practitioner on the campus of these smaller hospitals, but if you can leverage technology like teleneurology where they can actually be at the bedside with cameras and do the analysis that they need for patients who are having a stroke, whether they are going to administer treatment there or transfer the patient. Those are the kinds of things that these models will support, will stand up and recognize and pay for.
Have you looked at what Alaska is doing within the IHS? They're extremely, obviously, rural, and IHS has their own issues, their own problems, which, we're working through that on a task force. Being Cherokee myself, I understand it, very well. But Alaska has seemed to be ahead of telemedicine, they just don't have that access to the care that it's not reasonably for them to be able to get into, and a lot of dynamics factors play into this when you start talking about having to fly people in and out. And so they don't have a choice. They've been forced to do it, but they've been successful at it. Are you familiar with it? Have you looked at it at all?
Not in detail.
No.
Maybe I suggest you maybe taking a look at that. Another question, what is PTAC doing to encourage applications in rural and underserved areas?
So we are, again, reliant on the proposals that are submitted, but I will say in the first year before the Secretary's criteria were finalized, we had several public meetings with stakeholders across the country, and we were very clear, and we continue to be very clear, that we are encouraging small and rural practices to submit proposals, that we are receptive to receiving proposals. We see that as a significant area of need, and we're trying to foster everything that we can do relative to our process to make sure that we are open and willing, and we make it as seamless as possible for these smaller practices to compete and build these models for our evaluation.
So what are some of the barriers? And once again, we're looking to work with you.
Right.
So what are some barriers that is standing in your way from this side? Because I'm assuming if there was barriers that you could already take care of, you would already done that. So there must be something that we're keeping that from happening.
Well, again, one of the barriers that, again, keeps coming up is the need for technical assistance, particularly among small and rural practices who might not have the resources. I think we do need to find a way to offer that. Again, I think some of the measurement systems in some of these models could actually be beneficial for small and rural practices or critical access hospitals, which often have higher patient experience scores. They might be recognized for the things that they are already doing well. So I think looking at measures and technical assistance, and again, the data needs for these practices, they can't necessarily build analytic teams, nor should they need to. So how can we make it easier, reduce provider burden to actually just have the information they need to give the care that they're giving?
And just to make a point on when you said your patient's experience, which we put a high value on that, which I agree it's about customer service, but it's also about care too. A lot of times the reason why you see that, in my opinion, is these rural providers, they're personally connected to the individual.
Absolutely.
When my father had a major heart attack and actually coded, he was right at the hospital. And the guy that was working there, who's a good friend of ours, knew my dad well. And when he couldn't speak, he couldn't say anything, knowing the personality my dad typically has, immediately recognized it, and it saved his life. But I think that we take it more personal, but we're getting farther and farther behind. And we, as a committee, really want to help with that. And personally, as a member, I want to work with you. If you have ideas, if there's something that we can do, if you recognize areas that we can push on this committee, please use our office. Use me as a resource, because I'm going to be using you as a resource. Yes. Thank you, and I yield back.
Thank you. Thanks, the gentleman. The gentleman yields back. Chair recognizes the gentleman from North Carolina. Mr. Butterfield, 5 minutes for questions, please.
Thank you very much, Mr. Chairman. Thank you for convening this hearing today. Dr. Bailey, let me just direct 1 or 2 questions to you, and then we'll see how much time we have left after that. But first of all, thank you so very much for your testimony. Like the gentleman from Oklahoma, I represent a small rural community in eastern North Carolina. And so I'm very interested in your comments to him and to others about the challenges facing small rural providers and taking advantage of the APMs. And so I guess question 1 would be, what proportion of the 32 letters of intent and the 20 full proposals are from small and rural practices?
I don't have that number available. It's more than 1.
You just don't have it with you?
I don't have it with me.
You don't, but you do collect the data?
Yes, we do, absolutely.
All right. Number 2, has PTAC observed differences in applications from large practices and small and rural practices? Do you discern any differences between the applications?
Well, the applications are highly variable from application to application, and I think...
In terms of quality?
Right.
Quality?
In terms of sophistication and how they're built. So there's clinical sophistication, and then there's the payment policy sophistication, and both components need to be present for our recommendation to carry weight and to garner our support. The area of technical assistance, I don't want to say that the smaller practices are the ones that are needing more technical assistance compared to the larger, more sophisticated practices. I'm not saying that, but we have found in both arenas, in both practice cohorts, that there have been challenges with their model. More so on the payment side and the data side, not so much on the clinical side.
But you do acknowledge that there's room for improvement in many of the applications.
Absolutely, yes.
From the large practices to the small practices.
That is correct.
But wouldn't you acknowledge at least that the weight of those, the majority of those, are more toward the rural practices because of the lack of expertise? I mean, we hear that every day up here, where disadvantaged groups just don't have the expertise to present the quality proposals that you would want. Do you communicate directly with the small and rural practices about the benefits of technical assistance? Do you let them know that it's there for the asking?
Actually, one of our key challenges is that we are not, at this point, allowed to offer technical assistance. We have made available the resources that we do have. So to the extent that the committee can organize data for applicants, we are doing that. But so far, we are limited from what...
But you can't proactively go out and advertise that it's available?
Currently not, no.
Didn't know that.
We are charged to evaluate the models as they stand. We cannot provide guidance. We cannot make recommendations on how the model should be reconstructed. That is not in the purview of the PTAC, and we're careful not to go into that area at this point.
All right, let me try it this way then. Have you worked with Health and Human Services to share your experiences with applications and make recommendations about how to deploy resources and technical assistance? At least has HHS been made aware of this?
Yes, and the committee sent a letter to Secretary Price naming technical assistance as a key need for applicants. So we certainly weighed in on that need.
All right, I'm about to run out of time. Let me move to a different subject. Dr. Bailey, I'm acutely aware of many of the health disparities that affect African American citizens today. Several of the approved APMs deal with chronic disease management like ESRD that disproportionately affects minorities. Can you discuss with me some of the APMs that are being considered that would disproportionately affect African American and other minorities?
We are currently evaluating a model for hepatitis C, which I would think, I believe, I don't have the numbers specifically in front of me, the demographics, but I believe that is another challenge, health challenge that, just like end-stage renal disease with the African American community. So those are two that come to mind.
We're out of time.
Gentleman's time has expired. Chair would inform the gentleman that I am getting a copy of the letter that the Physician Technical Advisory Committee sent to the Secretary in August, and I will make that available to you so that you will know the communication that occurred from this group back to the agency. The Chair now recognizes the gentleman from Florida, Mr. Bilirakis. 5 minutes for questions, please.
Thank you, Mr. Chairman. I appreciate it so very much, and I thank the panel as well. A few questions for both of you. Can both of you discuss your experiences in transitioning to value-based care outside of your work on the Physician-Focused Payment Technical Advisory Committee, and how has that influenced your view of what advanced alternative payment models can deliver? Now, I know that some of these things have been covered, but if you could respond, I'd appreciate it.
Sure. Well, I will speak to my experience, which is quite different from Jeff's, but I actually used to work in a very large health system, so had some experience there as they were trying to transition their practices. But more recently, I've worked in multi-stakeholder groups in various communities from Hawaii to Maine, where they are bringing together employers, health plans, providers, patients, state governments, others, to try to come up with payment changes that actually meet all the stakeholders' needs. So is it getting value for the money? Is it improving patient outcomes? And are clinicians actually happier providing this care, and is it better suited? Are the barriers being removed? It's actually that multi-stakeholder alignment that enables the transition. So that is, and we have tried various models, ACOs, bundles, patient-centered medical homes, and implemented those in different communities.
Thank you.
So in my experience supporting large physician practices, multi-specialty group practices, there's a tremendous amount of inertia to work with the physicians and the clinicians to get them to change their practice styles and move away from fee-for-service, volume-driven practices to focus more on outcomes. The models I've deployed in my former leadership roles relative to supporting physicians and clinicians, paying them for quality outcomes, paying them for collaboration with their colleagues, paying for their utilization of electronic health record. There has been, and I think there continues to be, some challenges with galvanizing the level of interest. There's challenges with the data that typically we hear from the physicians that as they move away from volume, you know, does the data you're sharing with me that you're now going to pay me for accurately reflect the work that I'm doing? So there's, I think it's washing out, but there was obviously on the front end of moving from volume to value a healthy dose of skepticism from the physicians. Well, you're going to pay me differently, but am I actually going to get paid for the work I'm doing? And so it is very challenging, but I think right now what I'm seeing is that the mindset of the physician and the clinician is they know they need to do it. They know they need to move away from the fee-for-service environment, pure fee-for-service. And the question is, how do we do it? And at what pace do we do it? And what tools are you going to provide me so that you're not overburdening my practice? Elizabeth talked about the $40,000 per physician just to monitor and track quality. But I would also argue there's another 750 hours, I believe, that was in that same study that each physician has to devote to monitoring and managing and measuring and reporting quality. I'm here to say that as a health plan, we had 188 quality metrics that we were holding our physician community accountable for. I don't want to get into the weeds, but I'm sure you think that is not optimal. Yesterday, the board of Blue Shield approved moving to an integrated healthcare association set of metrics, 34, and we are going to lead the way in the state and try and get a standardized set of metrics, 34 metrics, it's not boiling the ocean, to actually have and change outcomes and drive this value and try and take the burden away from the practitioners.
Could I just add, I think that is absolutely essential to not only reducing burden and cost, but actually allowing physicians to accelerate improvement. And the other element of that report is that there was only 5% overlap in commercial plans for using the same measures. If they could do what Blue Shield of California did and agree to use a common set, that makes life easier for physicians, and it can lead to better care at lower cost. I think it is just an exemplary move, and that one that could easily be replicated around the country if folks were willing to do that.
Very good. We'll take a hard look at that, and I'll submit my questions for the record because I don't have time. Thank you, Mr. Chairman. Appreciate it.
Chair, thanks, gentlemen. Gentleman yields back. Chair recognizes Mr. Green of Texas for any concluding thoughts that he might have.
Chairman, my concluding thoughts, I want to thank you for the work you're doing, and I think we just have a long way to go, and we will do what we can to get you some resources so we can move it. Again, my biggest fear is we're going to end up 17 years from now doing what we did with the SGR, and medical practice is more important than that. So hopefully get some stability there. So, and thank you for your work, and keep in touch with us. Let us know what we may be able to do.
And thank you for your support.
Thank you.
Thank you.
And just recognize myself briefly. Dr. Bailey, I think it's important to note that you all were chartered January of 2016. It took some time to organize and staff up. So it's really just been a little over a year that you have been at work on this, and as someone else pointed out, you do have day jobs as well. So it is, I mean, I picked up perhaps on some criticism that you weren't active enough or doing enough. I'm actually pleased with the work product that is coming through the PTAC right now, and I believe that and I think I heard your testimony that there is more, it appears there's more activity on submissions, and I think that's good, and I think that's important. I think we all recognize that there's a tremendous amount of work ahead of us on this. One of the things that I do feel obligated to mention when this concept for the Physicians Technical Advisory Committee came up, when the legislation to repeal the sustainable growth rate formula was being contemplated, some of us are less enthusiastic about all aspects of the Affordable Care Act. And there are portions of the Affordable Care Act that to me are disagreeable because of the coercive nature of the Affordable Care Act. So the individual mandate would be one of those things, and I'm well on the record about that in this committee. But the Center for Medicare and Medicaid Innovation, CMMI, which had the ability late on a Thursday or Friday afternoon to simply roll out a demonstration product that was going to be pushed out to the entire country with no cost-benefit analysis, with no randomized clinical trial. I mean, this was a problem that I saw that we were careening towards. And the Physicians Technical Advisory Committee, in part, was created to help us offset what I saw was an impending disaster with CMMI. Now, I think it's very helpful that Ms. Mitchell has pointed out the small-scale testing. You know, it might be reasonable to find out if something works before we require every practice in the country to behave that way. CMI was set up differently. Your model is, I think, the correct one because, yes, I was integral in setting it up, but still, I think your model is the correct one. And we acknowledge there are elements of the unknown. This is new territory. There are going to be things that we encounter that we did not expect. And unlike the Affordable Care Act that was perfect when it was passed and has required no adjustments, this, I recognize, may require adjustments going forward, and this committee is going to be nimble about accepting those and providing you with the legislative backdrop that you need to do your jobs, and we thank you for doing your jobs. Thank you for being here today. It's been a very informative panel, and you are now excused, and we will transition to our second panel.
Could we?
Again, we'll thank our second panel of witnesses in advance for being here today and taking the time to testify before the subcommittee. Each will have an opportunity to give an opening statement, followed by questions from members. And let me give you a moment to get seated, and we'll proceed with the introductions.
Mr. Chairman, before our witnesses leave, I would offer again, if you want to sit down and work on the how we can agree to 7 years later on the Affordable Care Act, I'd be glad to do that.
Have always been available to you. Very good. Again, we're going to have each of you, after your introductions, an opportunity to give an opening statement, followed by questions from members. So today we're going to hear from Dr. Louis Friedman, the American College of Physicians, Dr. Daniel Varga, Chief Clinical Officer, Texas Health Resources, Dr. Bill Wolf, CEO of Central Ohio Primary Care Physicians, Colin Edgerton, American College of Rheumatology, Dr. Brian Kavanaugh, Chair for the American Society of Radiation Oncology, and Dr. Frank Opelka, Medical Director, Quality Health Policy for the American College of Surgeons. We appreciate each of you being here today, and Dr. Friedman, you are now recognized for 5 minutes for an opening statement, please.
My name is Louis Friedman. I'm pleased to share with this committee my perspective and that of my national organization, the American College of Physicians, on alternative payment models under MACRA, specifically the Comprehensive Primary Care Plus program. On behalf of the college, I wish to express our appreciation to Chairman Burgess and Ranking Member Green for convening this hearing and for allowing us on the front lines of patient care to share our experiences in the transition to value-based care. ACP is the nation's largest medical specialty organization, representing 152,000 internal medicine physicians who specialize in primary care and comprehensive care of adolescent and adults, internal medicine subspecialists, and medical students who are considering a career in internal medicine. I am board certified in internal medicine and I'm a fellow of the American College of Physicians. Since 2001, I've been in private practice in Woodbridge Medical Associates in New Jersey, which has been NCQA certified as a patient-centered medical home, level 3, since 2008. Our practice is small, with just 4 physicians and 1 physician assistant. In the 3 years since our practice started participating in the CPCI program, and now, 1 year into the CPC Plus program, Track 2, we've gained significant knowledge of the benefits and challenges of the program. I would like to share my experiences with all of you today. Under CPC Plus, we've expanded our ability to analyze and deliver care to our patients have benefited in many ways. With the added financial support that the CPC Plus program provides, we've been able to offer self-management programs such as nutrition classes and dietitian visits. These are available free of charge to patients and have been well received by many who need them. For example, I've had one patient who was 6 feet 3 inches tall, weighed 442 pounds. He had high blood pressure and terrible venous insufficiency of the legs, which causes massive chronic swelling. He enrolled in our 8-week class and by the end had lost 31 pounds. He dropped another 10 pounds in the next 2 months and his swelling has improved. Now this is an extreme example, but shows that we can induce positive lifestyle changes, which in turn can help prevent disease. Feedback data from CMS is another tool that we did not have access to previously, but now do as a result of our participation in CPC Plus. Often patients simply are not aware that many medical issues, such as upper respiratory infections, rashes, minor cuts and bruises, can be easily treated in less expensive urgent care setting or office setting, often with a shorter wait time for the patient. Now we can review the number of patients, our patients, per quarter who were admitted to the hospital, seen in the emergency room, or seen in urgent care centers. Once identified, we hope to better educate these patients as to when and when not to seek emergency room care. Prior to CPC Plus, we didn't have this ability, and thus had no idea how many unnecessary emergency room visits there were. Pre-visit planning by ancillary staff and effective monitoring within the EHR have helped us to improve our rates of vaccination, screening procedures for mammograms, and diabetic eye exams. Screening tools for early detection of dementia have helped us at-risk families better prepare to care for their loved ones. And the CPC Plus reimbursement for managing these patients with this diagnosis has been helpful for targeting this effort. On a practice management level, regulations issued by CMS requiring EHR vendors to obtain health information technology certification have made it possible to track patient parameters more effectively. Prior to enactment of these regulations, EHR vendors had no incentive to create effective dashboards with which we can track patient measures such as blood pressure, blood sugar measurements, etc. Without this ability, there would be no way that a practice could hope to report the necessary measures for the program. As this committee and federal agencies look to improve upon this program in the future, I would like to offer some suggestions. First, there's a need to simplify the reporting requirements under CPC Plus. As more private payers enter the APM market, one option would be to streamline specific metrics across both CMS and private payer models. This would be in line with ACP's Patients Before Paperwork initiative and the ideas that the college has laid out for how to address excessive administrative tasks, as well as with the administration's new Patients Over Paperwork and Meaningful Measures initiatives. Another suggestion would be efforts should be made to encourage interoperability among EHR software vendors, which would lead to better electronic communication between medical offices and hospitals. And I would be remiss if I did not acknowledge that there is a financial incentive as well to participation. This is needed for the practice to maintain the appropriate staff and computer systems. However, I believe we must continue to move forward with value-based coordinated care, such as been found in programs like CPC Plus, the medical home, and other APMs, and away from fee-for-service system. Given the time and effort our practice has invested over the past few years to this end, as well as the significant and incremental improvements we have experienced, we plan to continue with this model and not return to a purely fee-for-service structure. In closing, I would like to note that since 2016, practice participation among ACP members in advanced payment delivery models is increasing, and many more have noted that they're making changes to prepare for successful participation in the QPP overall. This is the case for both ACP primary care and subspecialist members. Therefore, we in the physician community appreciate the opportunity to offer our input on how these models are impacting our practices in patient care, both now and throughout transition. We very much want to be part of this process and provide feedback whenever needed.
Chair, thanks, gentlemen. Dr. Varga, you're recognized for 5 minutes, please, for an opening statement.
Thank you, Mr. Chairman. Thank you to the members of the committee. My name is Dan Varga. I'm the Chief Clinical Officer and Senior Executive Vice President for Texas Health Resources and the Senior Executive Officer of the Southwestern Health Resources ACO, also speaking as a participant in Premier's Population Health Collaborative. I'd like to make 3 points to the committee. First, our decision to move to a two-sided risk Next Generation ACO was a direct result of the incentives included in MACRA and the fact that these alternative payment models, in our opinion, are working. We believe in a value-based healthcare system where incentives for all providers can be aligned and where healthcare providers are able to collaborate using an integrated infrastructure and transparent data on quality and utilization to deliver better outcomes for our patients. This is even more critical in North Texas. Because of North Texas's strong economic and population growth, more than 40% of practicing physicians do not participate in the Medicare fee-for-service program or severely limit their availability to fee-for-service beneficiaries. Thus, by participating in the Next Gen ACO, Southwestern Health Resources ACO has been able to keep almost 3,000 physicians in the fee-for-service model. And this includes faculty, employed, independent, PCPs, specialists, urban, and rural physicians. Moreover, because of our participation in a Next Gen ACO, we have waivers that allow us to partner with doctors to reduce the CMS reporting burden for our clinicians by reporting those measures for them as a group, earn bonuses by participating in the ACO, which creates important incentives to physicians to move to this new care model, have access to comprehensive data on utilization for our 67,000 beneficiaries, allowing us to better direct our care management activity to areas where it can create the most value. Can't point out enough that this data transparency for integrated providers is priceless and also allows us to clinically integrate within a set of safe harbors. In our experience, these models are working. In our experience with our 67,000 beneficiaries, we are among the top 10 Medicare ACOs in 2015 and 2016, saving $30 million in 2015 and $37 million in 2016. We've been able to garner and retain top talent, including 600 primary care physicians, 40% employed, 60% independent, as well as another 2,300 participating providers. Budget in 2017 and 18 to distribute over $22 million in incentives and gain sharing to independent PCPs alone. Make investments in infrastructure to support coordinated patient-centered care with a budget of $70 million in 2018 to go along with over $100 million in investments since the institution of our ACO program. To tighten our network of providers to create better outcomes for our patients based on objective clinical and efficiency metrics, and to better manage our ED and acute care utilization. We additionally have the benefit of participating in Premier's Population Health Collaborative. Since 2012, about 50% of the Premier ACOs have achieved shared savings, better than the approximately 31% experienced by the rest, while also outperforming on quality metrics. In 2016, 100% of the Collaborative's Pioneer and Next Gen ACOs achieved savings versus 50% otherwise. And we also have the advantage, again, referencing data, of sharing data not just on our beneficiaries, but on hundreds of thousands of Medicare beneficiaries and the ability to learn from our peers on how their markets are performing and how tactics in those markets can be deployed in ours. I share these results to demonstrate that while there's been concern that APMs are not delivering real savings, it's clear that with a balanced and planned approach and effective execution, these models can work. Second point is that these value-based care and payment models are a significant departure from the past, changing 50 years of culture and habit. There's a number of implications to that. First, the changes are obviously long overdue as we move from a fragmented fee-for-service system where providers are incented to do more services to one where competition will be driven by high-value networks that deliver differentiated outcomes. This work to better organize the healthcare market into high-value networks is necessary and desirable, and we would urge that folks make a differentiation between consolidation to create excessive market power and integration of providers in the market to create a high-value network. Policymakers should also be careful not to tilt the playing field to the advantage of one provider group over another and maintain a level playing field. And finally, while significant progress has been made to move to a value-based payment and delivery model, this Congress and administration should continue to build on these positive steps, as have already been mentioned. With needed changes, we believe more organizations will move to and succeed in APMs, and I encourage you to review the listed areas reform in my written testimony and those in Premier's Delivery System Transformation Roadmap. Thank you again for the opportunity to testify before this committee. You've made a vital and lasting impact on our nation's healthcare system with the design and enactment of MACRA, and I urge you to continue to build on this successful work. Thank you.
Chair, thank you for your testimony. The Chair would make an observation that it has been long a goal of mine to have a panel of 5 or 6 physicians before this subcommittee. This may be one of the first times this has happened in my experience. I wasn't really planning on talking about this aspect. I wanted to get 5 or 6 doctors in here to tell us how much economists should be paid. Dr. Wolf, you're recognized for 5 minutes.
Thank you, Chairman Burgess, Ranking Member Green, and members of the Health Subcommittee for inviting me to testify today. I am pleased to be here to share with you how the move to alternative payment models is working to transform the delivery of health care. I am testifying today on behalf of CAPG. CAPG is the largest association in the country representing capitated physician organizations participating in coordinated care. CAPG members include over 300 medical groups and independent practices in 44 states, Washington, D.C., and Puerto Rico. CAPG members have proven that APM-type models of payment and care delivery can lead to lower cost and higher quality. I also address you today as a physician and the CEO of Central Ohio Primary Care Physicians. Our group consists of 370 physicians, 200 adult primary care physicians, 60 pediatricians, 75 hospitalists, and 25 specialists. COPC is the largest physician-owned primary care group in the country. Let me begin by emphasizing a single point: the value movement is working. To underscore that point, I'll share with you our organization's journey into value-based payments and why being in an APM matters to primary care. We were formed in 1996 when 33 of us got together from 11 practices. Beginning in 2006 through 2014, we reported for PQRS when it was still PQRI. We deployed an EHR, and we're now on our 2nd generation EHR. All of our eligible providers met meaningful use. We too became level 3 patient-centered medical homes. All of these initiatives, every one of them, made being a PCP less satisfying in a fee-for-service world. In 2014, we entered into shared savings contracts with both commercial and Medicare Advantage payers. We sought contracting structures that reward PCPs for things that do not happen. If you're a primary care physician taking care of 1,500 patients and no one has colon cancer because they've all had their colonoscopies, you have created value. Value heretofore unrecognized by the primary care physician, but recognized by the employer or the payer. We developed programs to improve care. This meant expanding our hospitalist program, developing transition of care nursing, hiring care coordinators, having visiting physicians who see only 2 patients in crisis a day, and having an ER intervention program where our nurses intercept our patients in the emergency room. In 2016, we earned $12 million in shared savings for our primary care physicians that was returned to them. Our Medicare readmission rate on 4,000 Medicare admissions in 2016 was 7%. The national average is over 18%. The ability to reward primary care physicians for high quality and lower cost is crucial to the preservation of primary care. In 2017, we desired to be in a Medicare APM. We qualified for CPC Plus Track 2. CPC Plus payment model allowed us with prepayment to expand our existing care coordination, move towards capitated payment because of the hybrid model, and receive quality payments. In 2018, we will move to prepaid contracts with downside risk on 25,000 Medicare Advantage lives. Clearly, MACRA's incentives for advanced APM participation is the latest program driving us into new models of payment. Past programs have discouraged fee-for-service volume, and APMs are now rewarding value and creating value. We are thrilled to see that last week CMS announced its intention to create an advanced APM demonstration in Medicare Advantage. With 1/3 of all Medicare lives in Medicare Advantage, It is crucial that it be rewarded like fee-for-service Medicare. In the MACRA final rule, the agency states that participants in such a demo will qualify as an APM. This is a crucial step forward, and we thank the members of Congress, including those present at today's hearing, who encourage CMS to move forward. Thank you for the opportunity to testify. I hope it's been helpful, and I'm pleased to answer questions.
Chair, thanks, the gentleman. Chair recognizes Dr. Edgerton. 5 minutes for your opening statement, please.
Chairman Burgess, Ranking Member Green, Chairman Walden, Ranking Member Pallone, and distinguished members of the Health Subcommittee, thank you for the opportunity to speak before you today. My name is Dr. Colin Edgerton, and I'm a rheumatologist in a small private practice at Low Country Rheumatology in Charleston, South Carolina. I'm one of 7 rheumatologists in a single specialty group. Our practice is a typical rheumatology practice, with around 50% of our patients being in Medicare, along with a significant number of TRICARE patients and a smaller group of Medicaid patients. The remaining group of patients are in the commercial segment. Because South Carolina, like most areas of the country, suffers from a shortage of rheumatologists, our patients may travel long distances, commonly 1.5 to 2 hours, to see us and receive treatment. As a result, we see a mix of urban, suburban, and rural populations. In addition to my work as a rheumatologist, I'm also privileged to be involved with the American College of Rheumatology, where I currently chair the Committee on Rheumatologic Care. The ACR represents approximately 9,500 rheumatologists and rheumatology health professionals. Community physicians, including rheumatologists, are keenly aware of the opportunities created by MACRA for developing models to promote value-based care. Before MACRA, there really was no meaningful way for small specialties and small practices to participate in alternative payment models. As rheumatologists, we did not have the opportunity to engage in APMs. Our specialty simply did not fit into the previously existing value-based products. Coming from a community practice setting, even just a few years ago, I would not have considered myself someone who could get involved in an APM. But with the repeal of the SGR formula and institution of MACRA, rheumatologists saw for the first time a structured opportunity to participate in value-based medicine. There are several reasons that I and also the ACR have been excited to get involved in creating APMs under MACRA. Most notably, we immediately saw the benefits of APMs, recognizing that certain aspects of care provided by rheumatologists as cognitive specialists are undervalued in the current system. In many instances, the value of training and expertise provided by rheumatologists is not recognized in payment outside of innovative models. Additionally, non-face-to-face care and chronic disease care coordination with other providers are critically important but not reimbursed services provided by rheumatologists every day. And like other specialists that are developing APMs, rheumatologists know that these valuable services prevent costly or unnecessary procedures and lower overall costs. My early foray into value-based medicine involved reaching out to leaders in the AMA initially who had experience with value-based projects through CMS. This finally led me to the Physician-Focused Payment Model Technical Advisory Committee, PTAC, whose members have been generous with their time, listening to my ideas and guiding my progress. The ACR simultaneously has begun developing APM, and I've been fortunate to participate as a representative of community rheumatologists. The ACR's APM is approaching its testing phase, and my partners and I are eager to be a pilot site. The ACR's APM addresses the treatment of rheumatoid arthritis, a lifelong condition whose care depends on the stage of the disease. The APM reflects the varied involvement of the rheumatologist during these distinct stages of care, splitting payment into an initial stage for diagnosis, including, for example, communication with primary care physicians, followed by ongoing care stratified by the disease severity and other illnesses that complicate disease treatment. This model aligns payment with physician work and reimburses services that have traditionally been undervalued. Quality measures are built into the APM to ensure treatment adheres to best practices. Rheumatologists as a specialty are energized by the opportunity to provide our patients value-based care through this framework. We look forward to participating with more physician participation in APMs. Specifically, smaller practices are eager to participate in APMs as well, and allowing some of the downside risk to be covered could help those practices get involved. Regarding timelines, as soon as MACRA was codified, many specialties began to look at APMs, and I'm hearing that a reduction in the qualification thresholds could allow these eager physicians to utilize the APM framework. We appreciate the committee's work to get us to this point, and we look forward to continuing to develop and implement innovative new payment models that offer the opportunity to provide better patient care, aligning payment with highly valued services. Thank you again for inviting me, and I'm happy to address any questions the committee may have.
Chair, thanks, gentlemen. Dr. Kavanaugh, you're now recognized for 5 minutes, please, for an opening statement.
Thank you, Chairman Burgess, Ranking Member Green, and members of the Health Subcommittee. I'm a radiation oncologist at the University of Colorado. I treat cancer patients there. I serve as the chair of the board of directors for the American Society for Radiation Oncology, also known as ASTRO. ASTRO represents more than 10,000 individuals striving to give cancer patients the best possible care. ASTRO's membership includes radiation oncologists, nurses, cancer biologists, medical physicists, and other healthcare professionals. Close to 60% of all cancer patients will receive radiation therapy, and ASTRO's members treat more than 1 million cancer patients each year. Radiation therapy is a safe and effective treatment for cancer. It works by damaging a cancer cell's genetic material, thus stopping its growth. When the injured cancer cells die, the body's natural healing processes remove them. Most treatments are given as outpatient procedures, and so patients can maintain a high quality of life while receiving treatment. Of the million patients treated annually with radiation therapy, about 60% receive care in hospital outpatient departments, and the other 40% receive care in freestanding community-based centers. Radiation oncology centers have extremely high fixed costs. The minimum capital required to build one is approximately $5.5 million. Radiation oncology reimbursement rates have had cumulative payment cuts totaling approximately 20% for freestanding community-based centers in recent years. These payment cuts created instability throughout the profession, jeopardizing the viability of these centers and patient access to care. ASTRO very much appreciates Congress's longstanding support of radiation oncology, perhaps best exemplified by the bipartisan passage of the Patient Access and Medicare Protection Act of 2015, or PAMPA. However, PAMPA is not a permanent solution, and it only stabilizes radiation oncology payments temporarily through the end of 2018. We believe it's critical that radiation oncologists have an advanced alternative payment model before PAMPA expires. The Medicare Access and CHIP Reauthorization Act, MACRA, has provided ASTRO with an opportunity to pursue an APM that promotes high-quality care and moves us beyond the prior era of uncertainty. Recently, the Center for Medicare and Medicaid Innovation, CMMI, released a report to Congress which outlined design considerations for implementing an advanced APM in radiation oncology. ASTRO has proposed a radiation oncology alternative payment model, the RO-APM, and we are pleased to see that our proposal is concordant with the concepts for an advanced APM in the CMMI report. Currently, there's only one oncology-focused advanced APM, the Oncology Care Model, the OCM. However, ASTRO is concerned that this model does not adequately address the needs of patients who need radiation therapy. An RO-APM is needed to fully realize the benefit of multidisciplinary care for patients, and we believe that the RO-APM would complement and build upon the foundations set forth by the OCM. The RO-APM is designed to incentivize the appropriate use of cancer treatments that result in the highest quality of care and best patient outcomes. The model applies to a comprehensive list of cancer disease sites that account for more than 90% of Medicare spending on radiation therapy and include breast, lung, prostate, colorectal, and head and neck cancers. The RO-APM uses care episodes that are clearly defined by billing codes that punctuate the beginning and end of a treatment course and the 90-day period thereafter. An episodic payment rate will enable practitioners to focus on high-value patient care. The model features a two-sided risk corridor with an opportunity for shared savings, but also accountability for excess resource utilization. Throughout the episode, physicians must adhere to strict clinical practice guidelines. These guidelines help to ensure that patient care is appropriate and of the highest quality without over or under treating patients. In addition, the model rewards participation in a robust practice accreditation program and measures performance on accepted quality measures to promote safe, high-quality care. The RO-APM also rewards shared decision-making with patients, efficient communication with other providers caring for the patient, and survivorship planning. In summary, ASTRO would like to thank Congress very much once more for repealing the SGR with the MACRA legislation. MACRA has ended the significant instability associated with the SGR and created a forward-looking framework for the advancement of value-based care. ASTRO fully embraces the spirit and goals of MACRA and is committed to ensuring that radiation oncology can fully participate in advanced APMs to drive higher quality, cost-effective cancer care. The proposed RO-APM incentivizes the use of appropriate cancer treatments that produce the best possible outcomes for patients, helps rein in Medicare spending, can stand on its own or dovetail with other APMs, uses well-established guidelines, and contains key patient engagement components. After experiencing significant payment cuts under Medicare fee-for-service in recent years, the field of radiation oncology needs long-term payment stability and predictability to secure patient access to care. ASTRO is committed to moving full speed ahead to ensure that radiation oncology can participate in advanced APMs under MACRA that drive greater value in cancer care. The next step is implementation of the RO-APM before December 31st, 2018. Thanks for the chance to speak with the committee.
Chair thanks the gentleman. And Dr. Opalka, you're recognized for 5 minutes for an opening statement, please.
Mr. Chairman, Ranking Member Green, distinguished members of the committee, we thank you for the opportunity, the privilege to come before you today on behalf of the 84,000 members of the fellows who are members of the American College of Surgeons. MACRA to us created a unique opportunity for physicians to lead in the development of APMs. When you think about it, since the inception of fee-for-service over half a century ago, clinical care has become increasingly more complex. We have many more medications and technologies upon which to treat patients. And the only way to succeed has been for us to form teams of care around patients for which these patients suffer. So we have come together in thinking about alternative payment models in team-based episodes of care to add to the library of alternative payment models to be considered. We lacked the opportunity to build business models or payment models around team-based care until MACRA came along with the advanced APM opportunity. When you consider what has to go forth in building that APM model, there are 5 general principles that I think that would be helpful to think about as you do this. First is a clinical care model, something we as clinicians are all expert in. And those are those complex models of team-based care that have changed today. Second are the quality measures that assure that those models are effective. Third, what are the payment models the insurer has? That's that technical component that makes it difficult to build the APM. We as clinicians are not those who have the technical skills of building the payment model aspects. Fourth is changing our business operations from fee-for-service into these alternative risk-based models. And fifth, the actual structure of risk. What's involved? There are all sorts of aspects to risk. There's insurance risk, there's clinical risk, there's operational risk of having the right team ready to meet those clinical risks. The PTAC has been a wonderful experience for us. We learned with them. They were hypercritical of our model and helped us in framing the model and making necessary adjustments and corrections to the model. There was an enormous back and forth between our team, the American College of Surgeons, and our partner, Brandeis University, in building the APM model. We partner with Brandeis because of their knowledge in the Medicare cost measurement system and their role in developing the CMS episode grouper that's used by Medicare to frame the actual cost structure of different episodes. The episode grouper allowed us to provide risk-adjusted, patient-individualized significant target prices, not a bundle, but a patient episode price, extremely granular information that allowed us to create an operational model for national scale of an implementation of an APM. When we come about the quality aspect of this, the ACS has a century-long experience in multiple registries that we use worldwide in defining, measuring, and improving quality of care. Our ACS Optimal Resource for Surgical Quality and Care and Safety Division runs things like the National Surgery Quality Improvement Program. These gave us a framework upon which to build an episode-based measure framework. Stop measuring physicians and measure patients. How did the patient do? If the patient did well, reward the team. If the patient didn't do well, it's time to penalize the team. So let's measure patients and what they do and not the individual physicians and make us all have shared accountability because that's what patients expect us to do. We've added to this the ability to put in the phases of care across the episode. For example, in surgery, there's a pre-op phase, an intra-op phase, a post-op phase, post-discharge phase. We've also put in patient-reported outcomes, which we think create meaningful measures. So instead of measuring here and there across a surgeon's experience, we're measuring the episode for the patient. We think that's critically important. The episode-based measure framework, coupled with the EGM, allows us to create quality cost measures with teams of providers to influence the patient experience and outcome. Assigning risk. This is a difficult part. Asymmetric risk. We don't think symmetric risk, same upside downside risk, really draws in what we need. We think you need asymmetric risk, more upside to bring people out of fee-for-service into the model, and significant enough downside to protect the patients and the payer as well. So that's the nuts and bolts of what we put forward. The PTAC process has given us considerable experience and input, and moving forward now, we've gone through PTAC in December all the way through March with approval in April. That went to the Secretary, and within a couple of months, we heard back from the Secretary giving us further direction for further clarification, testing, and piloting with CMS and CMMI. We've been working with them almost on a weekly basis since then in walking forward in work groups to deal with intellectual property, refinement of validity and reliability of the modeling, further questions about how the EGM grouper is used in the model, and the quality and the risk adjustment aspects of the overall model. Once again, Mr. Chairman, we thank you and your committee for all your efforts in this regard, and we look forward to your questions.
Chair, thanks, gentlemen. Thanks to all of our witnesses for participating today. We'll move to the question and answer portion of the second panel, and I'll recognize Dr. Bouchon from Indiana for 5 minutes, please.
Thank you, Mr. Chairman. Thanks to everybody for being here. I was a cardiothoracic surgeon before I was in Congress, so I also reiterate what the chairman said about how great it is to have an entire panel of physicians here at the Health Subcommittee. A couple of quick things. The American College of Surgeons, Dr. Opelka, and others, proper risk, and this is a little off the beaten path, but proper risk stratification of patients and assessing patient outcome and how important that is. I mentioned in the previous panel the STS database and other data. You mentioned some databases. I mean, one of the things I've always been concerned about as a physician when we're trying to design what is quality of care, how important is I think individual specialties assessing the risk stratification in the patient group that is in their area. How important do you think that is?
So if we're rewarding based on outcomes, there's nothing more important than actually having accurate risk adjustment, and that comes ideally from clinical data. So we have worked in this modeling with folks like STS. How do we use the STS database to validate the current risk adjustment, and how do we use future versions of STS in this modeling to make enhancements? We think that's the kind of work that needs to be done so that you get proper risk-adjusted pricing as well as proper risk-adjusted quality measurement.
Anyone else? Dr. Wolf?
2 comments. I think data is useful not only for risk adjustment to identify your high-risk patients, but we as primary care need accurate data to identify value in our specialists. Historically, a primary care physician refers to a specialist based on either knowing them, their kids play soccer together, they train together. We think a specialist is quality, but data is so important as we in primary care seek value for our patients, and we can identify that through data.
Dr. Varga?
Yes, sir, and we would agree further. Probably the biggest issue for us is having adequate data, as mentioned, to be able to do risk stratification, but it's not just simply to get the right pricing. It's actually to understand the level of care that the patient requires at any point in the continuum, and then understand how to match resources to that level of risk stratification. It's critical whether you're talking about a primary care scenario or whether you're talking about a complex cardiovascular surgery case.
Anybody else have
I would agree. From the rheumatology perspective, we know that our patients with rheumatoid arthritis suffer from other comorbidities that have a massive impact on their outcomes, but that's also important when we're looking at the cost of their care. We've struggled to extract that data from our EHRs, despite the fact that we spend large amounts of time entering data into the EHRs. We've designed a clinical data registry called a RISE registry as a college to help us do that, to extract some of that data, but it continues to be a struggle.
Okay. Yeah, because I agree with everything everybody said, because I think government agencies and tend to maybe think if you give a couple of data points in healthcare, like overall morbidity or overall mortality, without getting a bigger, deeper dive, especially specific deeper dive, you can these things don't work out that well because it's just not specific enough. Dr. Wolf, you probably know I co-led the letter to CMS about certain payment arrangements between Medicare Advantage plans and physicians as advanced APMs under MACRA. And I understand you mentioned CMS has come out and said that the new MACRA rule that they would be initiating a demonstration project to test the approach. And I know CAPG has been a leading voice in pushing this. So can you talk about the importance of APMs in a little more depth than you did in your testimony as it relates to Medicare Advantage and why CMS should move quickly along with this demo?
Yes, and thank you for that effort, Dr. Bouchon. Just like as we entered into shared savings and now risk with Medicare Advantage, we were able to provide for that subgroup of our seniors certain benefits that we were able to pay for with a per member per month payment. Through CPC Plus, we were able to expand those benefits to all of our seniors. So just as we are now with APMs recognizing and providing programs for Medicare, it would be unfair to exclude the 1/3 of patients in Medicare Advantage from those type of fundings that all medical groups use to create coordinated care. So I think it's important that all programs are for all seniors, fee-for-service Medicare and Medicare Advantage, and I think this is a step in that direction.
Okay, thank you. I yield back, Mr. Chairman.
Chair, thanks, gentleman. Gentleman yields back. Chair recognizes the gentleman from Texas, Mr. Green, ranking member of the subcommittee. 5 minutes for questions, please.
Thank you, Mr. Chairman. I want to thank our whole panel for joining us today. Dr. Varga, I understand that transitioning from a healthcare organization to an alternative payment model can be challenging, and there are a lot of moving parts to consider. In your testimony, you discussed how MACRA encouraged the Texas Health Resources to participate in the next-gen ACO model. Can you speak a little more about what it's like at Texas Health Resources before implementing the next-gen ACO model and why this model was best fit for your organization as opposed to an APM?
Yes, sir. Happy to respond. As I pointed out in my oral testimony, first and foremost for Texas Health Resources and for the Southwestern Health Resources ACO, this was an issue of access to care, with a large percentage of the doctors in North Texas not participating in fee-for-service Medicare program. There is a very difficult scenario for folks who are aging out of commercial insurance and aging into Medicare, actually finding a primary care doctor, and in some situations a specialist, who actually accepts patients in the fee-for-service model. A bit of workforce constraint as well in the Medicare Advantage program there as well. One of the things we really wanted to make sure we did with this is by offering the incentive programs that come through the next-gen alternative payment model, we're able to actually incent physicians to participate and continue to see Medicare fee-for-service patients. I think the other thing that we're experiencing in this is the ability to really coordinate care across the full continuum with our physicians, whether it's specialists or primary care. We've already shown that we can generate savings in the model. We've already started to demonstrate that we can actually, in very targeted areas with adequate data, start to decrease, which in North Texas is a big issue, which is overutilization of post-acute services, whether it be rehab, skilled nursing facilities, or home health. So the program has made an incredible impact on us, and we, like Dr. Wolf's group, believe that we can extend that into the Medicare Advantage program as well as we move forward.
How did MACRA and the opportunities it created hasten this decision to engage in a delivery system reform and participate in the next-gen ACO model?
I think probably the reason that MACRA accelerated this is in the MSSP Track 1 program that we have historically participated in, the cap on upsides really created a model that, in terms of looking at what sort of benefits we could return to physicians in that model, was relatively limited. The other piece of the Track 1 model that was very different from NextGen is some of the waivers we get in NextGen to be able to more aggressively coordinate care across the full continuum and actually take in different sorts or adopt different payment models like advanced care coordination fees, subcapitation, actually full cap, really creates a model where we can actually get our group of folks to manage these patients across the full continuum. The ability to create value both for the patients and for the physicians in the network is far superior to the model we had in Track 1.
What was the challenge to get your providers to get comfortable with the level of financial risk posed by the next-gen ACO model?
Well, that's one of the reasons that we believe in this integrated model is that, as it was mentioned earlier, the concept of asymmetric risk is one that's tolerated in this. So given that the health system and the Part A expense of the model is usually the most expensive piece of this, the health system provider can absorb upfront the bulk of the risk, both the risk incurred by building infrastructure, but also the potential for downside risk, and the ability to help physicians manage that piece as they went forward. So we really had very little resistance to the providers stepping into a two-way risk model.
And what type of infrastructure changes in provider education did Health Resources require to implement that next generation ACO?
The biggest change above the MSSP Track 1, which we've been in for the last 3 years, was really a far more aggressive care coordination model for mostly the post-acute world. That's really in our ACO where the data points us. We had already undertaken a fairly significant investment that allowed us to help our doctors get onto a common electronic health record platform with us, a common disease registry platform to point out gaps in care, and a common analytics platform for reporting. So the biggest issue was actually in putting the technology and bodies in place to be able to do the post-acute care coordination model.
Mr. Chairman, normally as a lawyer, I have plenty of lawyers in the room. Today we have plenty of physicians. And I think that's what's important, to make sure you're comfortable with what we're doing. And again, not recreating an SGR that goes 17 years and really hurts medical practice and your patients. So thank you for having the hearing.
Chair, the gentleman yields back. Chair, thanks the gentleman. Dr. Friedman, Ranking Member Green brings up an excellent point, and as I was talking to you before the hearing convened, I can remember a morning, probably 2005 or 2006, when I had to face a room full of your participants all sitting around little round tables down in a room in the basement of this building. And it was significantly stressful. I thought everyone was going to be eager to hear what my thoughts were on repealing the SGR, but nobody wanted to hear what they were. They just wanted it done, and they wanted it done last week. So I felt the anxiety. Only took us 13, 14 years to get to this point, but it was largely your group, that group of doctors that morning, that really provided the lift and the thrust to get this thing done. Your doctors ever talk about that now? Are they grateful the SGR is gone, or have we just moved on and we're at the next thing?
Sorry, so just repeat that last part of the question.
Well, are your doctors, do they talk about things like that now? Are they grateful the SGR is gone, or are they just worried about the next phase?
I think it's a mix. I think, I spent a fair amount of time polling my colleagues in the office before I came to do this, and I get mixed remarks. I say, from the standpoint of patient care, we've seen some big benefits. The care coordination is improved, and outreach to patient is improved. We don't go to the hospital anymore. We're strictly outpatient doctors, so we're in the office. And from that standpoint, we've gotten very good at retrieving the information and getting the patients into the office, so there's continuity of care. So those things have been great. And I'd have to say that the fee-for-service model was not working for us. I mean, had we not embraced this model, had we not embraced CPCI and patient-centered medical home early on, and now CPC Plus, we would have sold our practice to a larger system. So I think they would all acknowledge that. That being said, I think the administrative burden that we see in the office, the physician's administrative burden, and also my administrators, the amount of work that she has to do has increased, and that's a bone of contention.
Very good. Dr. Varga, you, in your testimony, talking about that Premier doesn't simply want to employ physicians, you want to create those high-value networks. So you have doctors who are basically private practice doctors who are working within your network, is that correct?
We do.
And kind of a 60-40 split on that between employed physicians and independent physicians?
Right. With the 60 being the independent PCPs.
How do you allow them to maintain their own independent practices and at the same time conforming to the measures that you're requiring to improve outcomes?
It's a good question. I think the biggest issue for us as we started was actually getting everyone to commit to a pluralistic physician model, where in large part we're largely agnostic to the physician economic relationship with the health system. So as we said, we have faculty, we have employed, and we have independent PCPs. We also have independent specialists who participate with our ACO in a non-exclusive fashion through a series of structures that we've built inside the ACO. I think the common thread, Mr. Chairman, is simply that independent of the economic relationship folks have with us, we all have aligned incentives, we all work off of a common infrastructure, and we're all held accountable to the same clinical performance metrics. And we really believe that it's highly valuable to have that pluralistic model in play, because an employed only model really tends to drive you to one sort of structure. It can work, but you don't really learn from the independent practice proposition. You also don't learn from folks who are non-exclusive to your network as well.
So you also talk about the anxiety and complaints. How's that part of it going?
You know, it's actually gone fairly well. We are fortunate in North Texas that the economics of the two-way risk ACOs are actually a little bit better than they are in some other areas of the country. So we have been able to produce shared savings at a fairly hefty rate for the last 2 or 3 years. We still have complaints, and I think one of the things that we'll start to really encounter as we go forward is we have not yet had to really drive the narrowness of the network in terms of... We have not. In large part because the physicians have largely performed to the set of standards that we've set in predominantly a one-way risk model. As you get into a much more aggressive two-way risk model, as you get into Medicare Advantage, the importance of really high-performing physicians becomes absolutely critical.
Dr. Edgerton, your practice would, of all of the different types of practices that I worried about as we were doing this, your highly specialized small office, I mean, that was the one that I thought was going to have the most difficult time with any sort of adjustment along these lines, but you've done it. Is that right?
That's correct, and we're approaching now that pilot phase. One of the real benefits has been the interaction with PTAC. Interestingly enough, because they can't reach out to us directly, It was largely looking at the PTAC website and the way that they are so transparent and studying the feedback they had given to different models that were similar to what we were thinking about and being able to learn. It's sort of like a university of APMs if you spend enough time on their website and see the comments that come both from PTAC and from other stakeholders. So that's really been useful in moving us along, not only as a small office, but also as a small specialty.
Very good. I do need to observe that we have a vote on, and I do want to recognize Mr. Guthrie for his questions. Dr. Bouchon, we probably won't have time to go to a second round, if that's okay with you.
Do me yield to you? Do you have any more questions?
No, I'll yield to you, and please go ahead with your questions.
Hey, Larry, I'll ask one quick one if you want to go with that. Okay. Dr. Varga, since joining an APM, what have you been able to accomplish, and what do you hope to accomplish in the future with regard to patient outcomes?
So I think the first thing that we've been able to accomplish, and I can't emphasize this enough to the committee, is number one, we have, for the first time I think in history, had comprehensive data on the population of Medicare beneficiaries that we're managing, which opens up a world of opportunity, as folks who are physicians would tell you. If you give doctors useful, reliable, timely data, 99 times out of 100, they'll make the right decisions off of that data. And so it starts with that. I think the second piece is we've been able to align incentives with our physicians, our hospital providers, and our post-acute providers to really take a patient-centric, patient-oriented approach around quality and efficiency and be able to really drive that care model. I think we're excited about the savings we've generated. We're also very proud of the quality metrics we've generated within the program as well. And I think the last thing that I would say in that is it's really turned the culture. We think far more in an ACO-centric way than we do in a hospital-centric way now, because our lives live in the ACO, and we coordinate care in the ACO. The hospital is one very small.
Thanks. I know I have a couple of physician friends here that have practiced under this. They may have a different perspective. I want to make sure they have a chance to ask what they want to ask. So, Dr. Pallone, I'll yield if you want any more time.
Thank you. I appreciate that. Hey, I mean, this is more on a personal level. I mean, I think for those of you that are in an APM, do you think participation in an APM has affected positively the quality of life of physicians in all of your practices, and the job satisfaction amongst physicians? Because I think all of us know that there has been a decreasing job satisfaction amongst physicians in all specialties over maybe the last 20 or 30 years, and our ability to recruit quality people to go into all of our specialties maybe has become a little more difficult. So do you think participating in these APMs and the way we're redoing the system maybe will improve those circumstances? Anyone want to comment?
I know it's my time. We just probably one time for one answer, and then we're going to have to go vote. So go ahead, Dr. Wolf.
I would comment from a primary care standpoint, absolutely, that we are able to get to a payment model that rewards quality instead of volume, and this does that, makes all the difference. And I've been asked before, what's the tipping point for this? And it actually is not financial. The tipping point is physicians understanding that you can get them into a contract model that will pay for quality and pay for value. And so absolutely, these type of payer contracting relationships have changed our physicians' lives and made a very difficult clinical life much more palatable.
Thanks. I wish I had more time for everyone else, but we're called to the floor, so I'll yield back my time to the chairman.
Gentleman yields back. The chair appreciates that. We have a series of votes on the floor. It's going to consume some time, so I think we can conclude the hearing and dismiss you all and not have to reconvene after votes. But I do want to thank all of you for being here today. We have received outside feedback from a number of organizations, and I'd like to submit their statements for the record. The American Association of Nurse Anesthetists, the American Society of Anesthesiologists, the American Medical Association, the American Physical Therapy Association, Health Leadership Council, American Society of Clinical Oncology, AHIP, the HSSR Coalition, American Hospital Association, American Association of Nurse Practitioners, the Society of Thoracic Surgeons, the American Academy of Orthopedic Surgeons. Without objection, so ordered. Those will be made part of the record. Pursuant to committee rules, I remind members they have 10 business days to submit additional questions for the record. I ask witnesses to submit their response within 10 business days upon receipt of the questions. And without objection, thanks again. The subcommittee is adjourned.